Share screen. Uh, Good afternoon, everyone. I'm sorry we are starting a little late, 20 minutes late, because we had the graduation ceremony of our outgoing batch of genetic counselor, and the speeches and all went a little long, as you would expect. So we start now. And as you would have seen in the program, we are focusing on the ethical, legal, social implications and the socio-cultural dimensions and ethical dimensions of cancer genetic counseling and testing. We are not going to talk about syndromes and detailed management about syndromes and types of genetic testing. It will be more focused on how do we deal with these issues in the clinic. And the reason why we have kept a global perspective is because some issues are very common across the world, and some scenarios are peculiar to a particular healthcare system. And it may be because what the laws of that country, what are the major beliefs of the people of that country, the socioeconomic factors, the autonomy for women and children in that particular society. So I have faculty from Australia, Brinda Sane, she's here. And she is a principal genetic counselor in Brisbane, Australia, Queensland. For Malaysia, online, Dr. Suki would be joining. Yoon Suki, she is a very senior genetic counselor. Again, she trained from Australia more than 20 years ago, practices in Kuala Lumpur, and does a lot of research. And from India, along with me, Neena Bhatnagar, who is a very senior, perhaps the senior most genetic counselor in India. And she was at Tata Hospital as a scientific officer for a few years. Then Dr. Dipanjana Datta, who's a senior genetic counselor and geneticist at Kolkata, and Dr. Aparna Dhar, who's again a very senior genetic counselor and also a precision medicine expert in Delhi Max Hospital. So can I have the next slide, please? Can you hide the controls? Someone is controlling my hide floating controls. Okay. Okay. So, and along with us, the international team, I've already mentioned from India. Then from Middle East, Dr. Abir Al-Sai, who's a medical geneticist. And from UK, London, NHS, Ariba Khan, who was again a genetic counselor with us. So, and now she's in NHS. And in US, Srika Amin, who was a genetic counselor with us, and now she's practicing in US. And along with me there are three themes. Then there are rapporteurs here, Judith and Akanksha. This is a batch which has just graduated, Anchal and Anjana, and Sushmita and Gopa. And this current batch, they're all volunteers. And a lot of things that you see which is happening behind the scene is because of our social media and outreach team, which is Payal. She's a really powerhouse in this. And Rashi, whom you heard in her acceptance speech, who's in Goa right now. So we have three themes. Theme one is availability, cost, and cost, access, and barriers for one is counseling, genetic counseling, germline genetic testing, and if you have found a mutation, cascade testing for the family and their counseling. The second theme is access, compliance, and barriers for high-risk screening. Someone is found to have a BRCA1 mutation or MLH mutation. Then risk-reducing surgeries for BRCA1 and 2, and precision oncology approaches for BRCA and MMR. And theme 3 is confined to ethical, legal, and social implications for a person who can be considered disadvantaged or vulnerable. What is the legal framework to safeguard such individual and families? And what are the genetic counseling approaches to safeguard this thing? So these are our three themes. And as I mentioned, so this is the summary of this thing. So I will now talk for 5 minutes just to set the theme. And after me, Vrunda will again speak. And then we will have, three speakers from India about all the three themes each. And then we will have from different countries where they will cover how these things matter in their region, in the practice that they do. So this is something which I had made many years ago and which is, I don't think it is changing, unfortunately, that people who are genetically predisposed, they are eminently suited for early detection and prevention. There are cancer prevention program. There are some, today we have MPH students here, Master in Public Health students, they talk about cancer screening, prevention. But here we are talking about these individuals are at a very high lifetime risk of developing cancer, specific cancer. Risk can be identified by genetic testing, and cancer morbidity and mortality can be prevented. When they go out for public health screening programs, they have to screen thousands of people with lots of efforts, and then they save one life. Here you have to just screen 5 people and you will save one life. So it's really the lowest hanging fruit, but really the scenario is, and today you can, early detection and prevention is possible. But in low and middle income countries, including India, such individuals, despite being aware of their family risk, they often present in late stages. Only some are lucky who are referred for genetic counseling or testing. And clinical and molecular syndromic diagnosis is seldom made in the pre-symptomatic stage. That's when you should be picking it up. And actually, even after cancer diagnosis, it is not made. Most of the genes, we don't have the penetrance estimate for that population. And the big issue is the cost, access, and compliance for testing, not just testing, screening, and preventive surgery. So all these aspects we'll be covering in today's lecture. So this is one slide which is many years ago, I don't remember who were the genetic counselors in my team that time who did this, about 120 mother and daughters. Maybe Nina was there and Payal, I don't remember. We just asked them about the issue. These are women who had breast or ovarian cancer. 3/4 of these women, they had the guilt of passing the risk to their daughter. 2/3 of them had concerns related to daughter's marriage. And 1/3 of the daughters were certain that they would also develop cancer like their mothers. What was surprising, 1/3 of these women had not disclosed even among their relatives, because and the main reason was the fear of social stigma on daughter that might come. She will tell her sister will tell her husband will tell his mother will tell 5 other people, and it's a matter of 2-3 years. There'll be hundreds of people in that particular, community who would know that there is some gene thing, BRCA thing, or cancer thing in this family. It will become an issue in this. And they thought that daughter would become social outcast. So, when I started, I am a self-trained, I'm not a genetic counselor. Fortunately, no one questions me now. With so many years and gray hairs, no one questions me. I'm running a program, but I'm not formally trained as a genetic counselor. As all my genetic counselors said, I have learned from the families. And I've happened to dealt with 20,000 families. So maybe some 50,000 individuals. So I think they have taught me so many things. When I started, I had the myth that there's one large family where everything is shared. You say India, big families, things are shared, all these South Asian emotional people, they would sit and cry and tell everything. That is absolute myth. Each family and each person is different and rather unique. This you have to just listen to that person, give them time, then you realize they're two sisters. Sometimes even they may be identical sisters, identical twins, but they're two different people, completely different. So you cannot sort of generalize, we have a habit of stereotyping people, young people, old people, women, men, rural, this thing, different, region, everything we do, so that doesn't really work. So of course, there's face some common issues, and there's some issues which are unique. The common ones are concerns about their children's future and daughter's marriage, which is very common. It just runs through across the society. And then, many other things which are unique. And I think the concerns, we know that, which we are having this, the availability, access, and cost of testing, counseling. And counseling is equally important, not just genetic testing. And then, of course, the medical, financial, and logistic support for lifelong surveillance. So now it should be done testing only after genetic counseling of the pros and cons. This is what we do call pre-test counseling. And the clinicians are now realizing its importance. So how I learned, so 20 years, 22 years ago when I had black hair, these are the people, first time I met some genetic counselors. They had taken me, this is where Myriad Genetics is. They had taken me to to show me on a hike, Color of Falls in Utah, Salt Lake City. So there's a Mormon, so they have family history museum, and it is ideal for genealogical research. And Myriad Genetics is also there. They were really they had a patent on BRCA gene, and they didn't allow anyone else to do, and that's why it was costing $3,000. So first, I spent 4 to 6 weeks full time with genetic counselor. Then I learned what wonderful people these are. They are a real bridge between, so you have a patient, then you have a family, patient's family, you have a doctor, you have a lab, you have a department, and all of us have our own this thing. So these people who would understand everything, as Mumbai they say, samajh ke lete hain, and then work around them. And the only goal is to help the person who is with them and also the family. They don't forget the family. So when as a doctor, when you say I'm only concerned with the patient, so they while they are primarily concerned for the patient who's come to me, they're also equally concerned about the family who may be at risk, as you would see. So with this, I will end. So our genetics clinic is here. It's a very busy clinic. Every year we enroll 2.5 to 3,000 new families. We have a lab in Actrec, which again does about 3,000 germline NGS panel, and I do report with my colleagues there. And we have an army of genetic counselors. Right now we have 15, including these 9 trainees of the first year. I would want more, and to help more people. And I'm very lucky to have learned from 20,000 families and a large number of genetic counselor. And each genetic counselor is very different. Their approach to the same problem is very different, I think. And I like that uniqueness because, you need the people also you meet will be unique. For some person, that particular genetic counselor will be most effective. I do not know which person who will be most effective. So that is cool. So all of us should maintain our individuality, but have to have the discipline so that professional discipline and confidentiality all are maintaining, and I'm sure they will be maintaining. And we were very lucky, we got a lot of funding, and I'm very happy that many institutes are starting. Just one thing I want to say, you can start something in a research program, but you see the participants of research get true benefit. In India, a lot of studies started doing BRCA testing in 2000 and all. So whatever patients participated, they got the blood sample, described the BRCA mutation, program closed. What happens to the family report, given, not given? No one really knows. So I think that is unfair to this. For people from whom you do research, get your publication, get your name and fame, you should help them and their families. That is very important. So with this, I will end and I will request Vrinda Sane to talk about this. And for 15 minutes she has, and then we will go one by one. Thank you, Vrinda.
I'm a genetic counselor. I've been one for last 10 years, and I think it's one of the coolest jobs, and I'm sure everyone in this room agrees. So I think, can everyone hear me? Yeah. So I'm going to start by saying Happy Genetic Counseling Awareness Day. We need one because nobody knows who we are. I saw once a video in which they said YouTube influencers, bloggers, and genetic counselors are new professions from 2005. And I feel very privileged that we are one of them. So congratulations to the new batch. And please do something special at your hospital on 15th of November, which is coming Thursday. We put a stall at the Royal Brisbane Hospital so that other specialties know that we exist, how to refer to us, and what we do. So doing something similar at Tata Memorial will be fantastic. So when we start talking about genetic counseling, that came a long time ago. 1947, the term was defined as the process of helping people understand and adapt to the medical, psychological, and familial implications to genetic contribution. Now we talk of completely different things. We talk of Mendelian disorders, which are single gene disorders. We are talking about multifactorial. So we have started doing polygenic risk scores as part of research now in our practice. And we are now testing patients. We are testing seemingly healthy individuals. Is the sound and everything is audible? Yeah, perfect. So I promise this is the only non-cancer slide I have, but everything else I'll speak about from cancer. So I worked in cancer genetic counseling from about 2013 till sort of 2020, and then also did endocrinology and cancers. And then now currently I work mainly in the prenatal and neurological genetic testing as well, but also see pregnant patients from hereditary cancer families. So I've got one example, which is non-cancer. I presume that's okay. So we have someone who has come in for genetic counseling, a woman who is currently 8 weeks pregnant. Her husband has bipolar disorder. so does his mother. And she is very worried what's the chance of her pregnancy or her baby having bipolar disorder, because it has been quite tough in spite of having medications. So when we chat to her, we speak to her about mental health conditions being multifactorial. There is nature as well as nurture, and bipolar disorder has a very strong genetic contribution. At the same time, it is not a single gene disorder. There are some genes that have been identified for schizophrenia, but not for bipolar. So when we give risk assessment, we say up to 20% or 1 in 5 risk of having a mental health disorder, if that's what is in your family. If both parents are affected, the chance of having a child affected is up to 50%. With that, we tell what the risk is. We also tell the hope, and there is no genetic testing available to the affected person, no genetic testing available in the pregnancy. Is this a genetic counseling session? What do you think? All budding genetic counselors. Yes? Yeah. So if we go by the current definition, and this is the definition by the Human Genetics Society of Australasia, which I follow and is a fellow of, genetic counseling is a communication process which aims to help individuals, couples, families understand and adapt to the medical, psychological, familial, and reproductive implications. So we did speak about bipolar disorder being multifactorial. We spoke about the risk, and nowhere does it say that we have to have a specific inheritance pattern to the condition. Neither does it say that it is about a genetic test, a result, or informed consent. It is a conversation. Patient-centered. We are tailoring it to the patient needs. We are goal-oriented. While we are counselors, we are talking specifically about a goal, which is genetic test and possible result, and how that will fit in the patient's family. Does that make sense? Yeah. So when we talk of genetic counseling, the process integrates a lot. And you have seen that the passing out batch as well as the current batch. So we are interpreting the family and medical history. We are providing education. We are finding teaching moments in there, in that conversation, that we are telling them what this genetic test is about. We are promoting informed choices. We are not leaving it to the patient, but we are doing shared decision making. And we are also providing support in one way or the other. So when we talk of genetic counselors, you and me, we are not doctors. We are trained in genetics and we are trained in communication. We build the bridge between the two, and HGSA, the Human Genetics Society of Australasia, uses professional genetic counseling, which is a genetic counseling session done by a genetic counselor or a medical specialist taking time to talk about the medical test. So many times what happens in genetic counseling, as the tests are becoming more and more available, that counseling becomes the test is available. Does the patient want it? The patient takes it and then gets referred to a genetic counselor when a gene mutation is identified. That's not the correct flow, but unfortunately, as we mainstream and more tests become available, that is what is happening. So that wasn't my plan, but anyway, there we go. So when we talk of genetic counseling, we can talk of them or divide them into two areas: the general genetic counseling or cancer genetic counseling. And we as a profession of genetic counselors are perfectly suited in the area of cancer. So general genetic counseling may have overlap for diagnostic testing. There may be a clinical geneticist, a neurologist, a cardiologist required to specifically phenotype. So examples can include things like ataxia or muscular dystrophy. May require a specific doctor doing multiple tests to clarify the phenotype. Some conditions like SCN5A gene, depending on the mutation, the phenotype could be Brugada syndrome, the phenotype could be long QT. So there can be an overlap with the same gene. Rare recessive conditions may require genomic testing. So if it is a rare condition, then panel, either exome or genome might be the right option. And different inheritance patterns can be seen in the same condition. For example, if we are looking at retinal dystrophies, inherited retinal dystrophies, they are recessive, dominant, X-linked. So multiple types of inheritance go in that. As against, cancer area is very suited for genetic counselors to practice independently. We generally have histopathology that can be deduced to decide what type of genetic testing we are ordering. Targeted genetic testing by panels for breast cancer, ovarian cancer, polyposis is available now worldwide. Many times, there is very clear phenotype and genotype correlation. So if you're talking about medullary thyroid cancer, you can be thinking of red gene. You're talking about diffuse gastric cancer, you can be thinking of CDH1. So there can be specific genes that you may target depending on a specific type of cancer and cut the need for panels. Or if you don't find a mutation, you can still think that the family has a clinical diagnosis of the same. In cancer genetics, apart from the exceptions such as MAP or MAT2I gene, most conditions are autosomal dominant. So again, easier, I suppose, in terms of giving that information to family members, and risk management guidelines are freely available and updated in a lot of cases. So there is a lot of information available there. So cancer genetic counseling or familial cancer services are very well suited for independent practice by genetic counselors. They provide service for people with family history of cancer, and this service can be for any family member, an affected person or someone who has been diagnosed with cancer or not. So we can provide genetic testing for the appropriate person in the family. You can always say, if you are diagnosed in your 60s and your sister had the cancer at 30s, probably she is the better person to undergo genetic testing in the family. You can talk about likelihood of carrying an inherited mutation in a cancer predisposition gene, information about person's risk of developing cancer, strategies that will reduce the risk of cancer, and early detection of cancer. So when I started working in 2013, I like to draw pictures. I mean, I still draw them, but then the picture was fairly simple. Breast cancer, that's all the cases of breast cancer. About 5 to 10% are because of these two genes, BRCA1 and BRCA2. We did Sanger sequencing and MLPA. Results took 3 months. And those were the two genes that we were targeting. Now, if I'm talking to someone with breast cancer, my picture looks a bit like that. We are talking about BRCA1 and BRCA2, which still sits at 5 to 10%. We have other high-risk genes like PALB2, TP53, CDH1, lesser. They are rarer, but they are there. We have the moderate risk genes, which are trickier. CHEK2, ATM, and few others, because what the associated risk is going to change according to them. And then now we have polygenic risk scores, which are going to add or reduce a person's risk. Not that the number will matter to the patient, but you may tailor individual surveillance based on that. So genetic counseling is changing. And if I have to take the example of breast and ovarian cancer only, we look from 1990 that BRCA1 and BRCA2 was invented, testing started, and 2009 things really picked up. That the NGS panels came around, and 2015 we can order as many genes as we want for a breast cancer patient. So the question is less more or is more less? So if we are talking about gene and population frequency, again, this is Australian data, but Australian population is made up of migrants. So it's not a particular ethnicity, but what we see, you will see that ATM gene change is found in 1 in 250 people. That's not 1 in 200 families, 1 in 250 people. So when we do panel testing, we are going to find these changes. May not be BRCA1 and BRCA2, but we'll find carriers of MUTYH very often. That's what we are going to see. We will find MSH6, which also can be incidental finding, and we will find a number of genes together in a panel. So our talk is going to be much broader. So is less more? We have option of panels now. So this is panels from Peter MacCallum Institute, which is, I dare not say that, but not equivalent, kind of comparable to what we have in Tata in India. That's the big cancer institute in Australia. They have options for multiple panels, the broad ones encompassing many genes, and then they have separated breast, ovarian, prostate, and pancreas, separated renal, separated tumors, colorectal cancer and polyposis. And depending on the patient need, if more is what they are looking for, or they would rather just know the information, genetic counselor can tailor and order what they want. So while we are patient-centric and while we are setting the agenda, that is something we can choose from. So patient who is in front of us is an adult learner. They're there to make a decision, but they also have their own things that they want from this genetic counseling session. So we want to find out, when we are going to talk about genetics and gene testing and results, what does the patient want? What are they here for? Do they truly want to have genetic testing? Are they rather seeking for information? Do they rather not have this genetic test? And our agenda should be mutual. Let's talk about this and see where you want to go at the end of that. So the patient has to be a partner in this learning process and decision making. And instead of sort of having patient-centric or not having a role to play, it has to be a shared decision making what suits the patient. So when we talk about models in terms of health behavior is mediated through what we believe and what we think. And knowledge alone is not enough to change the behavior. So genetic counselors have a role. We have an influential role in that session. We are in the position of sort of authority, knowing about genetic testing, and the patient is in the state that there is a fear or threat of a condition or a disease. And the powerful motivation could be, will genetic testing cure it? Or will it tell me more? So as I suppose we set that agenda, we got to treat the patient as an equal partner in the process, goal-oriented. That's where we are heading for. So when we talk of health behavior or what the patient wants, I guess I practice in Australia, we are practicing in India. I have seen some of your patients, and I feel that people come with an outward presentation, but the essence of human beings is very, very same. Whether we are practicing in Australia and seeing a Caucasian person, or we are seeing an Aboriginal person who is not very keen to engage, they are going to come with their innate characteristics. Some are very knowledge seeking. They want to know more. They want to know as much as they can because they feel in control. Or there are people that would rather know the bare minimum that they need to do to get through this, and they would rather not have genetic testing. So their essence is the same, and that's going to decide whether they want to have the test or not. Their siblings, children are going to influence that. So there is going to be that intrapersonal and interpersonal, institutional sort of influence, what the doctors say, what do we say, community or broader social construct, and public policy or insurance and laws. That's going to guide that. So when we see patient, we see them in pre-contemplation. If someone told them about genetic testing, they're not sure whether they want to do it or not. They see you, they've heard about it, they've Googled it, sometimes they haven't. They are before that contemplation. They sit in that session with you and they contemplate whether they want to have that genetic test or not. They make a decision and we want to be very much a part of it. And the action becomes the blood draw, signing the consent form. And from that is going to be follow how we are going to give them results. What do they do with results? Will they share the information with the family members? Will they engage in screening or strategies of risk reduction that have been suggested? So when we are talking about the panel test, and again, I'll go back to the hereditary breast and ovarian cancer, the possibility of finding a gene mutation from that 5 to 10% has changed. So 5% cases, we are going to find a gene mutation. But when we talk about young age breast cancers or family history, triple negative, the pickup rates in the panels have gone significantly higher. So we are going to find more mutations, and we are going to have, I suppose, broader we look for, we are going to find things. So the genetic counseling will have to encompass for incidental findings, for things that we weren't, I suppose the patient wasn't there for. For example, finding a Lynch syndrome mutation in with person with breast cancer, etc., is going to happen when we do broader genetic testing. So the patient education, what does the result mean? How this information can be used, decisions regarding the treatment, and plan for ongoing surveillance. That's going to be sort of contracted or discussed at the end of this appointment. And cascade testing. Who will the patient share the information with? How will they do that? Doing sort of a role play with the patient regarding how they're going to say that. Do I have the gene or do I have the mutation? What's the name of the gene? How will I tell my family, or how will I tell my peers? Providing a letter for the family members to give that, and a referral pathway to the nearest genetic service. So that will be the part of the discussion. Am I traveling okay for time? Yeah, 5 minutes? Sure. So when we are talking about barriers of genetic testing or surveillance, this is a case I would like to share. So this was a lady we saw in clinic at the age of 48 years with a second bowel cancer or duodenal cancer this time, which had MSH2 and MSH6 loss. She had a previous cancer at 34, a brother with bladder cancer, strong family history of bowel cancer. We did not find a mutation, but we could test or IHC the previous cancer because it was in the same family, it was in the same hospital, and we had the slides. The family did not particularly engage in surveillance in spite of having diagnosis of clinical Lynch, but unless the son had PR bleeding and he had a large tubular adenoma, again with MSH2 loss, genetic testing was organized by panel and an EpCAM gene mutation was found. So sometimes when there is a clinical diagnosis, a barrier for surveillance becomes lack of a gene mutation. And people or patients that you sometimes may see 10 years after or 5 years after, now there might be pickup on new information to what genetic testing that was done with them 10 or 15 years before. Technology is picking up more things and broader panels are giving us answers that we didn't have before. And that's just going to grow in the years to come. So when we talk of barriers, there are many. Fear and anxiety. Will I be getting other cancer? What would happen to me if I have a gene mutation? Will I be blamed? Will I be that person who talks to my family members? Lack of trust in the system. Why do they want to do this test? Is it commercial motivation? Can I trust these results? Burden of knowledge. Some people really like to be those ones who are burying their head in the sand. They don't want to be those people in the family that are constantly going to share information with other family members. There is risk of genetic discrimination in getting jobs, buying life insurance products and other things, and access to genetic services and genetic counseling can become a very strong barrier. I want to ask you all, what does high risk figure mean to you? If I had to say that it's high risk of a cancer, what number you will choose out of 100? If you were to just close your eyes and think for a moment, what does high risk figure look like to you? Akanksha? Out of 100, sorry? 70% is high risk for you? Yeah. Okay. So if there was a cancer gene or a software that detected and told you the lifetime risk was about 40%, what would that look like? Low risk to you. Yeah. So when we are talking about hereditary breast and ovarian cancer, we say population risk, which is low risk, is about 11 or 12%. Anything that sits up to 30% is moderate risk. And anything above 30% is high risk. And that's all of us genetic counselors who know these figures and kind of percentages. At the same time, anything that goes above 50% logically makes our chance of that happening more. So that is high risk for us. And this is us who are trained in identifying risk, where 11% is moderate. Anything big, up to 29 will go to moderate. Sorry, 11 is population, then moderate, and then high. Anything beyond 50 is high risk for us. So people will estimate that they'll definitely get cancer, or they don't care. I'll get it or I'll not. 50-50. World is black and white for them. Or they think it's unlikely if it is 30%. So that's what shapes people's behavior when we are talking about engaging in surveillance. Here was a case we saw recently. I'll wrap up quickly. Here is a case we saw recently. We saw this woman who had her mother diagnosed with breast cancer at 34 years, maternal aunt diagnosed with at 48 years and died at 50, additional family history from maternal grandmother. She was very sure that she was going to get breast cancer. There was no gene mutation identified in her family. She paid for her own test without getting anything. We used the software CanRisk to estimate her risk, and that came as 36%. So her risk of breast cancer in the next 10 years was 11%. However, her perceived risk was 100% in her mind. She was very keen to undergo bilateral mastectomy because she said, I'm a ticking time bomb. And that's what happened to my mother. That's what happened to every woman in my mother's family. That's what I want to do. While we were estimating her risk as different based on not having a heritable single gene mutation. So the risk can be perceived either or way. It can be perceived as high and it can be perceived as low. So challenges to risk perception can include lack of clear answer, no mutation, and other main barrier I find is the moderate risk genes, where you find the ATM or CHEK2 gene mutation, and the risk is going to be very different to every family member. The last part of the theme that I'll go through some of the slides and then end is safeguarding the patient. And a few things we can do at genetic counselors is medical documentation, shared decision-making and writing our and their thoughts together, advocating for the patient to the other medical practitioners, and providing support. That could be in terms of patient leaflets, family letters, giving them support groups that could be real, that are in the city or in the hospital, or can be something like Facebook. And then developing policies and practices at genetic counselors group together, developing clear guidelines for the department you are, respecting the consent if a family member is presented for cascade testing, and protecting the young and the vulnerable. So each sort of body governing genetics does write position statements about what can be tested and what should be tested for minors, etc. And as genetic counselors, we have to be that group that participates into developing that policies, because that the onus is on us as we go ahead in that. Here there was a patient that was referred to as post-test counseling. So she had acromegaly. So gigantism or acromegaly. She had a large pituitary adenoma and she was offered a gene panel in which she had a mutation in an AIP gene, which is associated with isolated pituitary adenoma syndrome. She had an identical twin. They both looked identical. Then she grew to 5 feet 11 inches. Her identical twin remained at 5 feet 4 inches. Both of them had bipolar disorder. Genetic testing was organized on one. AIP gene mutation identified. She came to genetic counseling clinic post-counseling. So the ethical issues in this case, the vulnerable patient, the one who had genetic testing, both of them really without any counseling, but the one who had genetic testing was the identical twin who was tested in this case. She was on medication, both of them, for the bipolar disorder. So they were vulnerable. Their right to decline was in a way taken away because it was part of a research setting, not really understanding what they were looking for. And the gene mutation identified, AIP gene, it's a new gene. There are almost no guidelines there at this point in time regarding what surveillance can be provided. So when we are talking about vulnerable patient, these also can be different group of patients that we will see in a genetics clinic. So the ethical, legal, social implications and things to consider, which are away from the obvious ones, are obligations as medical practitioners. If you are seeing a family, whether we disclose or withhold information, a disclosure of paternity, that can happen in recessive conditions in prenatal set testing, but you will come across that when you're doing cascade testing of both the parents, even in a cancer gene where new mutation rate is extremely low. So safeguarding yourself that there is a small chance that this mutation may have happened for the first time. We may not find it in either parents. How will you navigate that? Identical twins, the right to know, not to know. Genetic testing of children, if parents are separated, obtaining consent, capacity to take decision, mental health concerns, and lack of support system. So these are some things, I suppose, flags to identify in the genetic counseling session, how you can navigate along with that. And that's my last slide. So we are moving forwards with the new profession. We have to define our scope of practice, best practice guidelines, and put the patient first and put our own foot forward as well, so that we develop those things and come together as a department on consistency with certain things. Thank you so much.
Thank you very much, Vrinda. It was a very nice presentation and you brought in new sort of perspective. So I'm very happy. So we'll have the question answers later, because the next speaker, has to go on she's on an alumni trip, and Nina. So
I'm here.
You are there?
Yes.
So hope everything, we have not delayed you from your. So
one car has just left, so I'm hoping that I get a ride after that. But nevertheless, I'm right here in focus.
Fort she has to go. So 20 minutes. So we're taking theme 3 first, and then we will have theme 1 and 2, and then different countries. Please.
Thank you, Professor Sareen. Thank you, Tata Memorial Hospital and all the genetic counselors. with that, I'm going to start. Can I request somebody at that end to change the slides as I'm going through? Yes? Yes. Can we go to my first slide? Thank you, Sushmita and Gopa. You're on the next slide. You're doing the reporting on this session. Yes, that's right. And now from Vrinda's wonderful talk, she did a microcosm. What I'm going to be sharing really is a macrocosm. Can we go to the next slide? So India is a macrocosm in that sense. This is going to be a very non-scientific kind of presentation, because what I want to share with you in brief capsules is what India is all about. And India is all about various ingredients and the interrelationship between them, which then gives a complete, delicious output, which we all as genetic counselors have to be aware of and have to work with. Yeah. So we're dealing with the entire macrocosm of society, culture, beliefs, religions, family, and of course, hereditary cancer and inheritance issues. Next slide. So I've divided this macrocosm into 4 neat slices, hopefully. One is about beliefs and perceptions, both about cancer and about inheritance. Following this is the entire area about communication and family communication and dynamics. Another entire large area is both socio-economic and systems that we are working with, hospital systems and medical systems. And the last, which will be then taken over by the rest of the team, very competent and very good speakers, so I'm just going to touch upon it and hand over, is management and intervention and how it fits into this lovely khichdi, which is the ghee of the, it's a topping on the whole beautiful khichdi. Can we have the next slide? So the first area, which is beliefs and perceptions, in a snapshot, I found one study. Of course, there are very few. This was a very recent one, 2025. Details are on a drive, and I'll share it with you later. Is from an OPD. It's a small study, of course, but I want to show it to you just as a snapshot. So if you look at it carefully, midway through the results, you see a question. No, back to that slide. Yeah. Midway through this questionnaire, what kind of people get cancer, right? It says 50% of people believe that people with bad habits, so smoking, alcohol, drugs, get cancer. Another 25%, which is 1 in 4, believe that people who anger a god or people who don't believe in God get cancer. So it's just to show you what we're dealing with on a day-to-day basis in India and of course all over the world, but in different mixes. Another question which was put to them was, do you believe cancer can be caused by the following things? So cancer causation, ill wishes, God's curses, your own sins, immoral behavior. And these are large beliefs that we are working with. So when you have a patient, my young genetic counselors and my senior genetic counselors, it's important to respect that this is what is going on in their mind and this is what you're dealing with. So rather than talking at them, you need to talk within this kind of a mindset. Now, can we have the next slide? So another area in beliefs and perceptions is, for instance, these are again broad headings, and each of us will have many, many examples of illness causality. So God's curse was one of them. You see, you may have an agenda of what you want to tell them about how their disease was caused. 1 in 10 cancers are hereditary, but they have window shades pulled down in their minds, right? So you need to pull up that window shade, open their minds, and then talk about inheritance, and other practices, religious practices, their family networks, where they are in the hierarchy of society, the role they play in that family. Is it a dominant role? Is it a submissive role? Is it a wife? Is it a child? Is it an elder? Each person comes with a different attitude and a very different perception. Religious beliefs play a large part. So one of the main things that all the counselors need and do really beautifully is respect the patient and work within their belief system. So moving along, rather than focusing each, because each is a presentation in itself, and this is basically just to give you a flavor of how genetics works in India specifically, in a social cultural atmosphere. So the next one, can I have the next slide, is the area of spirituality. All right, what does the patient who's sitting in front of you believe how his disease was caused? You're going to try and tell him that it was caused because of inheritance, and because you inherit half your genes from your mother and half from your father, and one of those genes has an error, etc. So you're going to give all these explanations. That is your agenda, right? What are they coming to you with? All right, is it, what kind of misconceptions? So it's very important for us to probe what those misconceptions are. Do they believe it's bad luck? Do they believe that there is a ancestral curse? In Hindi we would say a dosha, which is how families, societies, astrologers, various people they go to will speak to them in that language. So you need to know and probe what are they coming with, so that you know what barriers you're dealing with. Again, this is just to touch upon these areas. We really need to have separate sessions in detail on each, but you get a flavor of what we're dealing with. All right, the next slide, just a little bit more on spirituality. For instance, beliefs. All right, beliefs can be both a positive and a negative. So if you find that they come with beliefs that they can deal with this issue of genetics or hereditary risks with support of the family or community or religion, then you can work on that, develop it to equip this person to cope better with what they're going through, with the surgeries, with their position in the family. Or are you dealing and pulling them out of a negative sort of a mind state? And how effective will you be? It will help you plan your your strategy of communicating with them. Yes, can I get the next slide? So which moves very easily into communication, because what this is all about is basic communication. And here you're not really dealing, in India or in many, many, many cultures, you're not dealing with nuclear individual families. You're dealing with entire network of influences which all act at the same time in a very high stress situation, which is a new diagnosis of cancer or a new diagnosis of hereditary cancers. So you're dealing with stigma that spreads in society about, "Arey, is family mein to bahut cancers hai." Sorry for our international speakers, a little bit of Hindi here and there just to give us our local Indian flavor, is that we're dealing with stigma that spreads very fast like wildfire, about that, "Oh, this family is cursed, it has hereditary cancers, don't even go near them." But then also that same family is part of the entire decision making process as to whether, for instance, it's worth it to spend money on a woman in that family and treat her cancer, which is expensive. We've had cases where that happens. Then there are breakdowns because children get angry with the family that says that, "No, we don't, there's no guarantee about the treatment, so we don't want to spend money on this." These are just random examples, but you get an idea of what we're dealing with. Again, shame and community. Now, hereditary cancers are all about extended families, right? We see 13 cases, 27 cases, we test 60 people in a family. So we are dealing with the extended community and the extended family. But if it's going to lead to shame, it will be suppressed. So again, we need to teach them coping practices. We need to teach them. Many of them would just want to not deal with it and say, oh, no, I'm just going to give them one line and then it's their responsibility. But then those are people who live with the guilt that, oh, my cousin got cancer when she was 23 and she has a 2-year-old child, and I could have prevented it had I told them in time. Again, like I said, I'm touching upon it so you get a flavor of what we're dealing with. The next thing on next slide, please, on family dynamics is when you're dealing with a diagnosis, right? We're sharing the diagnosis with this family. So is the fact that are they going to share or are they not going to share, is it ever brought up in your counseling session? And if not, is it your responsibility? And part of our training is that yes, it is your responsibility, because if it is to be a strong cancer preventive program, which carries risk for all family members, then how do you deal with secrets that are being kept in the family for all the above reasons that we talked about? Yes, and confronting it, working with it, and making that family cope with the rest of their extended family is part of our role. So these are inputs that we need to give and train our counselors in. How would, for instance, a young 25-year-old unmarried girl, how would she deal with her individual choices, which may be very contemporary, as compared to those of her elders, of her fathers, of her mamas, chachas, of her elder sisters, of her elder brothers, all of whom come with a different aspect of, and it's part of that khichdi of how she's going to go forward with her hereditary cancer issues for the rest of her life. So awareness and keeping all these issues in the back of your mind when you're counseling is one of the most crucial things that we need to be aware of. Can we have the next slide? One more about family and communication is marital issues. Yeah, it could be either disclosure or discord or support. You can have the entire gamut of of social structures that you're working with. So a mother will have, as Dr. Sareen showed us earlier, may have issues about whether her daughters will be marriageable if their genetic condition comes out into the open. There's ostracization in many communities and religions because of hereditary cancers. Again, like we said, this family carries a curse, so to speak. Then there are issues of personal neglect. A woman will try to hide her disease and her risk going forward with the rest of her family, which is specifically, we've had cases where in-laws have not even been told, and the woman will come to her marital, to her marriage, to sorry, her pre-marriage, which is her mother's home, to get her treatment and checkups done once a year. Because if she discloses it to her in-laws, she feels that she will be vulnerable and will not be accepted in that family anymore. Then there is things like survivor's guilt. Among siblings, two people have the hereditary gene, one person doesn't. The person who doesn't forever lives with, why have I got this special? I should also be suffering. Look at how much they're suffering. Their lives are destroyed by this. And why am I, in this good position? So even though they're happy, they don't feel that they have the right to be happy. Again, like I said, this is the entire area of communication and family dynamics that we deal with in each session. It's not a theory, it is what you see with your patient in front. Next slide, and I have two more and then I close. Next entire large area is this socio-economic status, as well as the systems that are available to this patient who's in front of you. So while we come with the attitude that education, this is a Nelson Mandela saying, which I love, is information, education, knowledge is a powerful weapon. And Gandhiji, Nelson, all of them showed how you can change the world. And this is the role you are playing as a genetic counselor. You're changing this macrocosm of a world for this individual who's sitting in front, and you can make the entire reality a very different reality for them. That is a power in your hands. Yeah. So what kind of socio-economic status are they coming from? Yes. Are they is healthcare accessible to many of them who live in rural areas? Are we just talking, do genetic testing, but they haven't a clue even of how to do an x-ray? So what are we really talking about? You need to be too very highly aware and respectful of their situation. What is their financial situation? Have they borrowed money just to get a bus ticket to come and meet you for the first time? And here we're talking about genetic testing, which costs 20,000 rupees, and putting them in a dilemma that it may be all over their family. High amount of sensitivity is required. Uh, Health literacy. All right, many studies, especially global studies, will show that this complex genetic information that we share is not understandable by many of the low literacy people that we deal with from villages. My personal experience from having worked in Tata Memorial Hospital since 2000, so that's 25 years of hereditary cancer families, is that that is not true. But of course, I don't have a study to back it up. Even the most uneducated, illiterate person who is just maybe a vegetable vendor, if you explain something to them clearly and with patience and with their own background in mind, they have completely understood. And I'm sure many of my colleagues in Tata will understand this. So, again, we don't take Western studies the way they are. We need to generate our own studies, which brings me to the last two slides. Can I have the next slide? While all of you are starting on your journeys in genetic counseling, and many of you are deep in it as a clinician, simultaneously, it would be wonderful to collaborate and collect data so that as we go forward, we have a tapestry of rich data, which includes all the ingredients we talked about in the last 15 minutes. So, other than genetics, we need to be aware of what is the socio cultural, economic situation, family dynamics, psychological dynamics that we're dealing with. And let's make a start and have our own studies, because our culture is rich and very different and very challenging. Last slide, please. The rest of my team, wonderful talks are due. We'll be speaking about this in detail. But I just want to leave one thought with you, which is that we need to train our healthcare workers, all of us, our clinicians, our lab technicians, that this is the reality that all of us are working in, and let us never lose sight of it. Let us parallelly develop our own systems and knowledge banks based on research of what we are seeing and dealing with. And that brings me to the last thought. Really, it's not a slide. Can I have the last one? By a eminent psychologist, and since our area is deeply embedded in psychology, Carl Rogers, a wonderful thinker, says and encapsulates this whole thinking beautifully. People are just as wonderful as sunsets if I can let them be. When I look at a sunset, I don't find myself saying, soften the orange a bit on the right hand corner, increase the black, increase the contrast, there's not enough light on the sea. I don't try to control a sunset. I watch it with awe as it unfolds. And I think to all working in genetic counseling, we watch with awe as our patients unfold their stories and live their future with the words and the knowledge that we give them in the small 45-minute time that we spend with them. So, my best wishes to all of you. And I would love to see many of you walk the path and fill up the blanks that we have in the earlier slides. With that, I'll close. I won't be here to take questions, but I'm very happy for you to reach out to me. The entire team at Tata has my details, and Professor Sareen, who has taught me everything that I know in this area, has all the answers as well. So you don't really need me. Thank you all. I look forward to meeting you in person soon. I'm sorry I'm not there. It's been wonderful, though, to be part of this session.
So thank you, Nina. It was a wonderful perspective. I think in genetic counseling, perspective matters because when we deal with individuals,
Yes.
people, it's their perspective, their systems, their belief system, and you brought it out beautifully. And have a great time with your friends. So they're having the 50th reunion of their, is that correct? Of
Yes,
your
it's a
school.
school reunion, 50 years after we
50 years.
graduated from
So you
school.
have told your age, Nina, then.
I have no issues with that.
So have a great time. Thank you
Thank
very
you.
much. I'm sure these our girls will, be there. So thank you, Nina.
Thank you, sir.
Bye.
Bye bye, everyone.
Huh. So I think now we have Dr. Dipanjana Datta. We are coming to again back to, so that was theme 3 she gave, and now we're coming to theme 1. Dipanjana is a very experienced and senior genetic counselor and geneticist, and she practices in Kolkata, and she will give her talk now. Dipanjana, you are there online?
Yes, sir. Yes, I'm right here, sir. Right here, sir.
And you have 20 minutes.
Yes, sir. Thank you so much, sir. Thank you so much for including me in such a wonderful session, and it's basically an eye opener too, like that talk Dr. Vrinda gave, Dr. Nina ma'am gave. So it's very interesting to hear. So I have been given the responsibility to talk on availability, cost, access, and barriers, and I thank Akansha and Judith and everyone who helped make these slides, and also Sir for including me in this session. So we will be talking about excess cost, availability for cancer genetic counseling, germline genetic counseling, and also for the the cascade testing. So if you can please change my slide to the next one, please. Yeah. So, cancer genetic counseling, as we speak, obviously you have got an introduction, but what about the excess? Like, we don't have such an army everywhere, as Dr. Sareen had mentioned. You have an army of 15 genetic counselors in Bombay, in ATREC itself, but is that true for other Tata centers itself? That's not true. And if we look at other places where cancer genetics is being offered, unfortunately, there is no such a great team that is waiting. The second would be that if we are looking at even Tata, the appointments, like if everyone has to go to Tata or an AIMS or specific places, um, first the knowledge, the referral to such places becomes important. So the referral system, if not in place, it will go haywire. And if we are talking about access, the other problem is that this is obviously a referral based system where every hospital does not have a genetic counselor. Every hospital is not doing the genetic testings by themselves, so they are probably outsourcing these tests. So it also comes to the fact that the patient might not also receive a genetic counseling even before they are being tested, and that creates a lot of problems. Also, even the professionals who are actually, say, talking to these patients, they might themselves not be aware of putting the essence of putting these patients and their family through the referral system. The second one would be the other part would be that in places where it is present, there is a lot of delay, and there is a lot of issues getting appointment and hindrance. So let us take this by an example. Say there is a patient who is coming from a rural area. rural area to Bombay and they want to schedule an appointment. But before they have this appointment, they have to spend time to all other clinicians before they reach, or they have to be referred so that they can reach. Now, this might take 15 to 16 days, and this person might not be able to wait over there for 15 to 16 days. You might say that, yes, there is telegenetics, but this person might not even have a particular phone, the smartphones to do a telegenetic consult as well. So this person, if the person does not come back, or if the person does not come back for the referral, then probably his genetic counseling or her genetic counseling is not done. The other part would be that, say, for different places, if there is a referral system and if they are actually going to have these kind of a referral system, is there basic surveillance procedures, or are there enough quality GCs who are actually going back and calling these patients back if there is something that needs to be looked into, say after 1 year, 2 year? Are we doing these kind of follow-ups? We are not. So if we are looking at it, then in India, we know that we have less than 150 genetic counselors. And if we have less than 150 genetic counselors, and this is just not cancer, we are talking about the entire system, 150 genetic counselors catering to a population of 1.4 billion. So obviously now, are they trained? Now, this 150, most of them are not trained enough in cancer genetics as well. Many of us have started our genetic counseling career doing cancer genetic counseling, because that was what was available, that was what was brought to us. But many of the newer people who are doing genetic counseling, for them, cancer is particularly a new field. So I would say there is also shortage of trained genetic counselor. There's shortage of genetic counselor, then there is shortage of trained genetic counselor. There is also shortage of the referral system, or there is lack of the referral system. There is lack of hospitals enough that are doing genetic counseling for cancer specifically. There is also an uneven distribution in the rural areas and the urban areas. Let us again take an example. We all know Milind Soman is advocates breast cancer, and he is running a marathon. Does this marathon awareness have any effect to the rural areas? Say I am coming from an island area of Sundarbans, or I am in Andaman. Does this have any effect? So again, there is the severe lack of awareness for those who are actually stuck in these rural areas. For urban areas, there might be something more dangerous that is also there. There are few places which are offering telegenetics, and there are few companies which are offering telegenetics, and without any counseling, they are offering tests. And this can be, again, a problem, because if something comes up, there is creation of anxiety, tension, etc. Can we go to the next slide, please? So when we are talking about this, there also comes genetic counseling is not free, and the entire system also comes with a cost. So when we are talking about cost, the cost the cost is attributed to the 16% of the cost for the entire genetic journey. As I just said, there are uncertainty of genetic results. Most of the insurance don't cover it, and genetic counseling is treated as an add-on. It's not treated as a primary consult, like in the sense, like after being referred, that it has to be done. Say I have been asked to go for an ultrasound or an MRI. If I will not miss it. But if it's a person who is uninitiated, or if the clinician just said that, okay, just go and have a genetic counseling without giving him a brief, this person will not actually go to the clinic, because they might say that I don't even know what will happen over there. Oh, genetics, I don't need it. I really don't need it. Or it's not important. Or there might be other things like Neena ma'am just said that, there might be other inhibitions that we were talking about, which like the social inhibitions, the discriminatory inhibitions, and this person might not end up in the clinic. So it is treated as an add-on. It's not really treated as a primary care or, associated care. It is basically an add-on. Now, in places where, this is also not there, it is also treated as a luxury. that sometimes what happens that I am scared or I'm afraid and I'm reaching out to some place where that place is not really good enough, or that place is not really trained enough, and I am falling into a certain concoction which I am not supposed to be in. So when we talk about cost, so cost is a considerable barrier for people, though I always explain this, that if you can be there, do all your tests, genetic counseling actually does not cost too much. But if you are not primed for it, I might think this as a non-essential consult, and I might not land up in that particular place, which can also become a barrier. Also, there is no insurance. There are no insurance. And also itself, the uncertainty of these, what is going to happen in there, what questions am I going to ask, and what will happen thereafter. I might inhibit myself from, seeing, because I am scared. So the cost is one part, obviously. The surveillance, whatever will be given, then I have to follow up. That is another part. Another part can be the uncertainty. The another part can be that the insurance is not covered, and treating genetic counseling as non-essential. Can you please move to the next slide, please? So we were talking about access, and when we were talking about access, we spoke about the number of genetic counseling in each hospital. We spoke that telegenetic counseling is available, but understand in some cases in the rural areas, also in some cities itself, there is only one phone, and probably the patriarch is holding it, and you are trying to counsel a small vulnerable woman over there who probably has no access to the phone, and probably this phone is on speaker, and she is sitting in front of like other 100 people who in the house who are hearing this counseling, which actually takes away their privacy, and also takes away the their confidentiality as well. Also, we don't have enough regional speaking GCs. Say I am able to do everything. Okay, the patient is able to do everything. But what if I am seeing a patient who is coming and who speaks Telugu and who understands nothing but Telugu? Then I will not be, even if I know my subject, even if I can counsel, I will not be able to counsel this person 100%, because I don't even understand the communication part. The science part may be there, but the communication part becomes zero. The other problem is that we still don't have any guidelines as far as like how to counsel for the newer genes that have come up, for the intermediate penetrance genes. Also, not every place has a multidisciplinary department. So even if I'm saying that, this is what the surveillance looks like, this is what the guidelines say for limited penetrance, or you have to come back to the clinic. These persons say that, what is my utility? I am ultimately not getting anything in return, so I'm not going to come back. If they don't understand, then there will be a gap. So about the online national medical records, because of this, I was actually searching for if there was any kind of policy which is there for us, like for India. I actually came across a particular policy called NPNCD, which was basically a national policy for non-communicable diseases. It has everything. It has got diabetes, it has got thyroid, it has got many other things, and cancer is also a part of it. But are we aware? Are we ourselves who are in the field are aware? And are there any record or registry that is being taken? The answer is a complete no, because I have traveled to many districts in East India, and if there is a cancer, even if there is a place where cancer detection happens, cancer treatment happens, all these data keeping, all this kind of counseling does not happen, and they would refer to a tertiary care center. And that way, the tertiary care center becomes extremely burdened to look for the entire place. In government system, how many places have a genetic counselor? We know AIMS has it, but does other places have it? The answer is again a balanced no. Are we keeping records? Except Tata, the answer is again no. So access is to genetic counseling in rapidly evolving technology and knowledge is also restricted, because the people we are reaching out to might not be in a state where they are able to actually reach out to these kind of technology as well. Once I went to this place, I was hiking, it was a monastery, and I went to this very high place. They didn't even have an internet tower. It was a place in Spiti. So they didn't even have an internet tower. There was only one person in the entire village who had a phone, and his phone used to work in one particular, rock, and that was it. That was their connection to the entire world. So we don't even know how many such villages are there where, this kind of thing is there. As far as the urban centers are concerned, we also don't we have a very bad compliance. Like I understand in Tata we have this where the coordinator can call back if there is a reclassification, but in most of the centers, even in very very big corporate hospitals, a coordinator is not there, a data keeper is not there who can actually call back these patients. So we are losing on in the genetic counseling field because we are losing the access to the patients, losing the access to give information to the patients. Uh, Again, if we have a precision reports, many a times genetic counselors are not allowed on tumor boards, and they are not allowed to actually be with the team or explain to the team, and they are given patients after everything happens and the patient is completely anxious and completely in a stage where they are not only they have been vulnerable, but now they are also anxious and they are frustrated to a certain extent. Next slide, please. So while I was talking about access, I was also highlighting the barriers. So one would be a lack of referrals. Second would be there was no prior genetic counselings, which we have discussed. Also the insurance policy, and there is also something called the genetic discrimination that we all understand. So there were papers that are there which actually show that, if a man has a diagnosis, the way he would access his siblings, he would ask his siblings to get tested or, go through the entire process. If a female has a diagnosis, same thing might not happen. Similarly, if a female has a daughter, the female might have this woman, this mother might want to test, but also have a lot of stigma in testing, because if something comes up, then marriage is an issue, or even if it is called an hereditary one, then there might be a social stigma against it. There is also great social anxiety. Like, this I've seen in my own family, where sometimes what happens is that if somebody gets detected of, say, these cancers, because there's so much talk in the urban areas about hereditary cancers. So if there is talk about it, we start feeling very insecure, and we go on to a clinician, or we go on to a place where we are not asked for genetic counseling if we have a very high like family history, but and there is no assessment done, there is no risk assessment done, but we are either asked to follow up by the clinician, or we are asked some random test which might give up some random reports, which becomes very difficult for this person later on. Also, the lack of funding, lack of insurance. Also, I would point out over here that there is no national policy as far as, this referral system goes. Like whether we are supposed to refer, whether we are supposed to keep a data, whether we are supposed to call back patients, whether we are supposed to, have a registry where we are reclassifying. These are done on one person's own will. It is not a standard which is given by the state, not a standard which is given by a national policy. Hence, in the district areas, in the rural areas, ultimately, we lose patients who don't even know that there is something called a genetic counseling, and that they can actually access to these kind of things. Another thing I would try to bring over here, many times we get patients where there is a pediatric cancer in the family and they want to have a second child. Many a times they are given random testings without even understanding that what kind of pediatric cancer there was. And these parents are also sometimes told not to have children because they would, again have a child with such a condition. Access to genetic counseling in these cases also becomes very important, but these are also cases which all cases don't reach to us. Then I said we are very less numbers, 150 looking after 1.4 billion. So obviously there is workforce burnout, there is compassion fatigue. Also sometimes, there are things where you are forced to do certain things which you are not supposed to. Like say you have a burnout or you have a difficult patient and you want to take a step back. It might be too personal for you, that case, and you want to take a step back, you want to refer it to your colleague. Those options are not there because we are so less. So this is an actual thing that happens. Also there is something called a compassion fatigue, like you are very compassionate, but because you are seeing large volumes and maybe something is happening in your own house at the same time, you as a genetic counselor, you cannot counsel that case because you are clouded up, but you don't have a place to refer them, or you don't have a place to shift them, because there are no second people there. uh, uh, so the other issue over here, I would also say there is a lot of free genetic counseling going on through the various commercial labs as well. And here there is also a thing called ethics, workforce ethics that comes in, where there probably the counseling is done more targeted towards getting a test done rather than if the person actually needs it or not. So this is also a barrier in the sense that the person might feel awkward or forced, and step back and not do anything else because the basic assessment was not done. Next slide, please. So when we talk about it, spoke about availability, cost, access, and barriers. Majorly, what we wanted to say over here was in the preliminary case, we are not the awareness might be low, the cost, the insurance might be not there, the access is limited to urban areas and people who are referred to these centers rather than the access being in the healthcare centers in the district urban areas or in the rural areas. And the barriers can be a social barrier, lack of referral system. It can be that there is a lack of funding, there is religious beliefs, there's workforce burnout, and there is less amount of trained GCs. Next slide, please. So availability, we already spoke about this a bit, that we have limited workforce, there is infrastructure for testing, but these are also concentrated in some places. And while genetic counseling is happening, the type of test becomes very important. We once had a clinician sitting in a city for a particular embryonic cancer. They had ordered a test that will never pick up those kind of cancers. So the knowledge among clinicians are also less about these kind of tests. So in itself, the awareness and the availability also becomes a problem. So when we say availability, these are concentrated to certain centers, and without them, the other centers, we actually don't get it. And hence it needs to be that if such a thing is happening, they have to come to these particular centers. Next slide, please. So again, cost, we already spoke about cost. There is a direct and indirect cost. The direct cost is the cost of the test. The indirect cost is how many, they are staying over there, probably traveling. They are also looking at other clinical radiology. They are looking at biochemistry. They are looking at other clinicians. They are also probably looking at, many other suggestions. So together the cost and the logistics becomes high. There is insurance only for government employees and not other people. So awareness of testing, physician referral pathways, multidisciplinary teams, limited database, and the storage becomes a problem. So access, availability, both are a barrier in many cases, and they are concentrated towards few areas. So as far as barriers, again, we got through all this, the psychosocial issues, the long tats, as we said, that if there is a pre-test happening, then the test happens, the patient is already back to the place, or they have to be called back in the same city, and there can be longer tats. There can be that can also be an inhibition for them to have a post-test counseling and surveillance. So again, the psychosocial taboo we already discussed. There are also, as Dr. Serene also said, that we have variant of uncertain significance. We also have right now gene of uncertain significance. So it becomes very difficult at certain cases unless we follow up. We need to sometimes follow up the database, follow up the patient, and there the patient might not be agreeing to come back. Those can also be the barriers. Next slide, please. So again, for genetic testing, these are again concentrated towards certain places, certain tertiary centers, certain bigger centers. The districts, the rural areas don't have it. We need to choose the right lab, the right test. Otherwise, again, there might be confusion, their cost might increase. There are both direct and indirect costs. Ayushman Bharat was supposed to have bit of these costs, but they don't at the moment. As I said, we have these centers like NP, NCD, which are not really functioning for cancers. There are also limited databases, physician referral pathway, the multidisciplinary team are not present everywhere. Also, the barriers of psychosocial, religious, longer tad, delayed reports, geographical issues are also there. And the major one would also be variant misinterpretation and over-reporting and over-testing. Next slide, please.
Can you sort of conclude it, please, Deepanjana?
Yes, sir. Yes, sir. So as far as cascade testing, we did talk a bit on cascade testing, where we are testing parents and other family members. And in this case, we did talk about that there might be a gender bias. There might be also a bias as far as, who to get tested. Like if I am a person, I might, in a patriarchal society, I might just want my sons to get tested and not my daughters to get tested. So that is again something that counseling has to happen. Next slide, please. And the burden of the surveillance also has to be there. So again, the emotional distress of an asymptomatic person that I might get something there and I have to follow becomes a ticking time bomb. And whether that person has access to that kind of infrastructure and effective counseling, maintaining records, what is the family dynamics, all becomes important. Next slide, please. So we discussed this again. It's the same thing. If there is poor family dynamics, if there is genetic discrimination, there might be a survivor's guilt. There also might be limited autonomy, where I said that the female is sitting in a place where she's being counseled, where it in a completely patriarchal region, where she does not have any access to zone where she can actually get a counseling by just sitting in one place and having her own private place. And the husband is talking, the woman is also not talking, or the father is talking, or the grandfather is talking, the woman itself is not talking. So these can be a problem with the cascade testing. Similarly, the stigma of familial condition, survivor's guilt, genetic discrimination, poor family dynamics, limited autonomy, privacy and confidentiality among the immediate family members, because they might just say, oh, she had it, so this had it. And as Sir showed in a previous slide, that it might just spread to the entire village, and which is ethically wrong. Next slide, please. So again, for cascade testing, there might be over testing, because that person might not need the test, or the person might be, accessing care which is more than needed. There can be a lack of resources, a lack of service, lack of infrastructure. Multiple family members might, if they need tests, the targeted testing might be again sometimes a problem as far as technology is concerned. Sometimes there might be the burden of the high-risk surveillance plans, and also the stigma that we have been speaking. I think that's the end of it. Thank you.
Thank you, Deepanjana. I think we'll have one more talk theme, and then we will have a discussion. Are you going to be online for some time?
Yes, I am here.
Okay, thank you very much. So now I invite Dr. Aparna Dhar to cover the theme 2. First, we had theme 3 ELSI. Now this was genetic counseling and testing. And now Aparna will talk about screening and prevention, as well as precision treatment. What are the issues, challenges in different parts of the world? And she'll speak about India.
Hi, good afternoon, everybody. Thank you, Dr. Serene and TMH, for having me. It's always a pleasure. I wish I was there to celebrate our GC. So, congratulations, guys. Super proud of all of you. And a huge shout out to Achal and to Anjana for doing this presentation, for making the presentation for me. You made my life so simple. Thank you, girls. So, this is actually their thoughts, their ideas, and I'm just presenting it for them. So, what we're going to be doing today is actually focusing on screening, prevention, and precision oncology in our individuals with high risk hereditary cancer syndromes. In particular, we're going to be talking about BRCA1, BRCA2, and our MMR gene, our Lynch genes. And I'm going to try and frame this discussion around the Indian context, where honestly, medicine intersects with family, culture, identity, finances, access, and emotions. And I think this is where our field kind of sits exactly at that intersection. That is what actually makes our work deeply meaningful. Now, in India, the journey that we've seen from genetic testing to surveillance to preventative surgeries to precision treatment, it's really not that linear. And even after a mutation is identified, decisions are shaped by geographic differences in healthcare access, your cultural beliefs about cancer and womanhood, your financial burden and lack of insurance coverage, you have emotional readiness and family support. You could even have sometimes fear or, avoidance rather than information gaps. So I think the question that we really is not only what do I recommend, but what we're also thinking is how do we support our patients to move forward or move towards decisions that feel safe, informed, and empowering. So with that, can we please move on to the next slide, please? Thank you. So when we look at a high-risk screening, and the challenges that we actually face, so BRCA and other high-risk genes, we do know that surveillance is pretty much well established, even with your Lynch syndrome associated genes. So you have your MRIs, you have your ultrasounds, you could have your mammograms, you've got your pelvic exams, you've got all of this where it's pretty well documented. However, implementation in India a lot of times faces barriers. One is the infrastructure gaps. Let's think about a contrast MRI. The availability is still more urban centric. And even if your second tier, third tier cities have it, it's also the radiologist who has to be reading those results. So you could have lack of expertise, lack of manpower that comes about there. Two, diagnostic inequity. We do see these between the metros and our second tier, third tier cities. And what I call scanxiety, which is essentially patients' fear of surveillance because they feel that it is actually associated with expecting a disease. They don't see it as preventative. So often I'll get a question, Ki, doctor, if I start screening, does that mean I already have the cancer? So counseling has to go beyond recommendation. It's not just about saying, okay, every 6 months do this, monthly do this, annually do this, but you actually have to sit down and prepare patients emotionally for lifelong surveillances. And let's not forget those financial, financial barriers and insurance gaps. So while genetic testing has become more affordable, sometimes in affected individuals, the insurance covers it because we don't know their therapeutic implications with that germline testing. But honestly, it's that long-term screening that becomes a real cost to our patients. So MRI breast screening is not covered by most insurance plans. Your preventative healthcare still is not viewed as essential care. And often what we tend to see, and I've seen this in my practice so many times, that the first 2-3 years, patients are religious in maintaining their surveillance. But then after that, especially for those where they cannot sustain finances, or more importantly, the emotional bandwidth for doing it, a lot of patients tend to drop out after 2 or 3 years. So a huge part of our role also sometimes, as much as we try and run away from it, is sometimes in helping families navigate through these, the financial navigations are sometimes required because it helps them to make and plan realistically and sustainably. Next, please. And we then move on to our risk reducing, when I talk about a risk reducing mastectomy. Now, we do know that this does significantly reduce the risk of breast cancer. There's enough data that has come about recently. There's Dr. Mateo's paper, which is actually showing a pretty much significant benefit in doing a mastectomy. But when we are making these recommendations, and especially in India, it's never purely medical, because breasts carry a meaning with respect to feminine identity, body image issues. You could have marriage dynamics that could be disrupted because of these changes, sexuality, and just the social perception about when somebody undergoes such drastic surgeries. And even sometimes when the patient understands the benefit, it could be the family, the spouse, the in-laws' opinions that actually strongly influence these decisions. So very recently, I had a case where I counseled a young 32-year-old female, BRCA1 positive, BRCA1 positive mother. She has a strong family history of cancer. She herself was diagnosed with a triple negative breast cancer. So medically, based on the family history, she was a very good candidate for a risk-reducing mastectomy with reconstruction. And her husband was very supportive that, yeah, you've got to do this. Let's do this. We don't want to do surveillance. Let's nip it in the bud before it happens. Let's reduce the risk. They were on board. But then there was the mother-in-law who said, why would you remove something that's yet does not have a disease? What will people say? And that's where the real work of the genetic counselor comes in, is the counseling that comes in, where you're addressing identity, you're talking about marriage, you're talking about self-image. It's not just about surgical outcomes. So eventually she actually chose to go in for a bilateral risk-reducing mastectomy with reconstruction. And when she came for a follow-up, what really resonated with me is what she said. She said, I don't feel like I've lost something. I feel like I prevented something. And honestly, that shift has come in where it's gone from fear to ownership. That's really the heart of your preventative care. And that comes from good counseling. And guess what? It doesn't just come from you as a genetic counselor. It's about working in conjunction with the surgical team, getting them on board while they are addressing the surgical nuances. You focus on the emotional, the psychological aspect of it, because she may be brave in wanting to do it, but at the back of her mind, she's going to have so many doubts. Talk to them. It's extremely important, especially in your young individuals. Next, please. So when we talk about risk-reducing salpingo oophorectomies, I think while this is definitely the most effective way to prevent ovarian cancers, especially in your BRCA carriers or even your Lynch syndrome patients, but it comes with surgical menopause. We have fertility implications, and there's obviously a lot of concerns about sexuality and self-perception. Am I going to be less woman if this goes? Is my husband not going to find me attractive? I may not have the same, is it going to affect the dynamics within my family? Am I going to suddenly age? Am I going to have hot flashes? How is that going to affect my interpersonal relationship at work, at home, everywhere? So there are a lot of concerns that come in, and these concerns are very real, especially in our Indian families, and it's not very often discussed. So there's this one patient that really, it's something that I learned from her, and that was that she was a 41-year-old BRCA2 carrier who, understood the medical recommendations when we told her that she needs to go ahead for a risk-reducing surgery. And I remember she turned around and she said, she was a sole caregiver, 2 children, she had elderly parents, and she told me, doctor, I will do the surgery, but I'm not doing it this year. I need time to prepare my family. So we also didn't push. We put in place a safe interim surveillance plan for her. We told her the shortcomings of those plans, and this was something that she was ready for. She was educated, she was informed about it. And she prepared herself emotionally, she prepared herself logistically. And it was actually a year later when she underwent that RRSO, and she was confident and ready. And it's what she said after that, that the difference was that we as a team, which included us, the genetics counseling team, was that you let me prepare for the decision and instead of reacting to it. So this shared decision making is what it should be. It should not be a persuasion of where you're saying, do this, this works for you. So it's very, very important in our counseling when we're doing this for our patients. Next, please. So we now come to the precision oncology for, with BRCA and MMR, and we know that how these actually influence treatment options and not just our risk. So if we're looking at patients with respect to PARP inhibitors, you've got your immune checkpoint inhibitors. So you've got your, in the case of when it's MSI high, when we see an MMR loss, and also the fact of when we can give prophylactic aspirin in those individuals who are going to go on surveillance for who have a genetic predisposition of Lynn syndrome. But let's be honest, while this seems wonderful from a treatment perspective, aspirin seems like such an easy drug, easily accessible. But even then, access is uneven. And there are a lot of reasons why it's uneven in our part of the world. I think one is definitely the cost. For those patients who are on, government panels or insurance approvals, a lot of time this gets delayed. So by the time they get access to a lot of this medication, we do tend to lose time. And then also, I do feel that there is a variability in the availability of those molecular tumor boards. How do we interpret these reports? If I'm going to be putting a healthy individual and recommending aspirin, that means there has to be a gastroenterologist involved. There has to be a cardiologist involved. All patients don't have access to these individuals, these specialists. And how much do our other healthcare providers, our general practitioners, our family medicine specialists actually understand the implications of these sort of prophylactic approaches or these sort of, targeted approaches? So it is a huge shortcoming that we do tend to see in our centers. And what we have started doing, I'm not saying it's all negative that we don't have access to this and we don't have access to that. But I do think somewhere what we are starting to see is larger hospitals who do have expertise like TMH has, some of the other private hospitals, we run a molecular tumor board and we do kind of do an outreach service where we try and extend our services outside our periphery and help those in the second tier, third tier cities in having the benefit of actually enjoying our tumor boards and getting expertise from our tumor boards that they can implement. But that's a very, very small place to start with. Another area that we require is I call them teletumor boards. I think that's really, really important that when you have those molecular reports, implications of molecular reports, sometimes you pick up incidental germline mutations on it. So having a heads up with respect to that, having somebody call these out in the tumor board becomes extremely important. So teletumor boards, I think, are important. You've got to have a centralized variant interpretation support system. It's not always easy, especially when there's a lack of trained cancer geneticists or trained cancer genetic counselors. And most importantly, we need to advocate for our patients with the insurance companies to show them the importance of all these tests and the implications, especially with respect to long-term surveillance, because I do feel precision medicine must be equitable to be meaningful. So I'm going to very quickly sum up by just two small things to say. One, I think in our field as genetic counselors, as cancer genetic counselors in particular, we speak in the language of genes, risks, and guidelines. But every counseling session actually reminds us that we're working with lives, we're working with families, identities, and we're working with people's futures. So a positive BRCA test does not arrive in a vacuum. It actually arrives into a family's history, a woman's sense of self, a community's belief. And our work as genetic counselors and cancer genetic counselors is definitely not to push decisions. Our work is to walk with people until they're ready to choose in a way that feels both, they feel safe and they feel empowered. And when we make genetic care empathetic, accessible, and culturally grounded, I think we're not just preventing cancer. What you're doing is we're strengthening families, we are changing generational health, and most importantly, we're creating futures. So on that note, thank you so much once again, Dr. Serene, for having me. And Anjana and Anchal, thank you so much for the slides. Thanks, guys.
So thank you, Aparna. Just stop the share screen and you want to come online and answer any questions. Suki is there in our office or at home. Okay, Aparna, both you as well as Dipanjana. Dipanjana, you are there or you have left? Okay. So
No, sir, right here. Right here, sir.
yeah, okay. So I think my one question to both of you, I mean, I see at Tata Hospital, we see the whole cross section of society, but any hospital, sometimes people feel that people who go to a private hospital, they're always rich and they can afford everything. But I think speaking to you all, so, the disparities, they exist across the strata of societies. And sometimes education and having a higher socioeconomic status, does it mean that you won't have, your belief system will change, you would have those issues? So would two of you like to address that from Indian perspective? Go ahead.
Sir, the main problem, I would say, the belief systems are everywhere in India. In fact, if we are going up
I mean,
this
it is everywhere in
strata,
the world, not just India, everywhere.
yes, sir,
So,
yes, sir. And
sometimes why
frankly,
I'm
if
saying that,
we
sometimes people feel that if you're not poor or if you're not illiterate, you're educated, then you will understand everything and you would be everything will be straightforward. That is a myth I want you all to expose.
I'll just talk about one of my patient without giving names. So this patient is a doctor, and she actually has a very strong history of breast cancer in her family. All right, and she knows that testing has to be done because she herself is a radiologist. Like, to break it down. All right, but when I was talking to her, and just as a casual talk, like it was a private moment, we were talking, and I asked her that, I understand you have a history. So have you considered testing? And the first thing she said was, no, I am very scared. I said, why are you scared? No, then, I have to be pulled into the surveillance part and everything. Everyone will know in the hospital. I will be discriminated. So if I have to test, I will not test here. I will test somewhere else where, nobody knows that I'm testing. So that is one, and that is very common. This is not a very
I think
uncommon
very
thing.
important point that our hospital system, we do not keep privacy.
Yes. Yes.
Okay, if you are an employee or if you are a famous person, your privacy just goes for a toss. So I think that is, but I'm so proud of the genetic counseling community and my team and everywhere. I think they are the only people who actually, keep privacy.
Yes.
So I think
Yeah.
that is very important, but that is not true for the other medicals and paramedical specialties. They feel okay. I mean, I'm just telling my friend, and that friend tells their friend. So I think that doctor radiologist is not wrong, because the whole hospital and the hospital everywhere, they would know that this doctor is going through this, and they will ask question, very cruel question. Oh, have you got cancer? They say, no.
Yes, yes, and that is one. So there was another case which I will mention, and then Dr.
Yeah,
Aparna can take over.
yeah,
There was this couple who had a child with embryonic rhabdosarcoma, and
yeah,
there was a DICER. There's a somatic mutation, DICER mutation,
yes.
and they wanted to have a second child. They had come for counseling. I had said, because it was a somatic variant, there's no need to go for a
Yeah.
prenatal diagnosis. They went to another person, and in another place, and they're not a geneticist but a normal gynecologist. And that person said, no, no, why are you even attempting to have a child?
Oh,
This
so
is
they
so
told,
wrong.
they ordered
Yeah,
you should not have a child.
you should never
So I think
have a
that is a
child. The same thing will
patronizing
repeat.
attitude of doctors of my generation. Hopefully the next generation will be better.
Ha,
Now you
so
want to
I
add
feel
something to it
discrimination is
just
there.
for a minute, then we will have Suki, give her talk.
Sure. No, I just wanted to add that I think one of the biggest misconceptions is those who are educated are the most easiest to communicate with. In the era of ChatGPT and Google, and I don't know what AI bots they come up with, they're sometimes the more harder ones to communicate with and actually, kind of get your information across. But I sometimes feel they require more patience and time versus the so-called uneducated ones. But I will say that I work in a private hospital, and sometimes it is so heartbreaking when we have patients I see who are below poverty line that we do tend to see, and we do tend to cater to them. We do see people who are coming from the CGHS, ECHS government profiles, and sometimes we can't offer them testing because they can't afford it. So we do tend to see this across the board, even in our private hospitals, and it becomes very, very difficult. And what I would urge genetic counselors, while a lot of times, the knee-jerk reaction is, okay, let's go ahead and let's do comprehensive profiling. Even something is understanding if they have a potential founder mutation, doing a simple PCR Asanga sequencing can also be very beneficial. And I'll be honest, I learned this from Dr. Serene when I moved to India, because I used to find it so frustrating that I could not, and having moved from the West, it was very frustrating. So this was one key lesson I learned from Tata when I heard Dr. Serene speak back in 2017, that This is how they actually address this lacunae. So sometimes think out of the box when you are dealing with individuals who may not have access to it. There are a lot of patient support programs. So befriend people in pharma. Free testing happens, maybe not the best quality, but sometimes something better than nothing. And a lot of times treatments are also available. There are, it's available on compassionate grounds. So as a GC, your role is not just about the psychological support and explaining the test, but befriend your cancer, your medical oncologists, your pharma people, because at the end of the day, you are the bridge who's connecting the patient to everybody. You play a very pivotal role. And if anybody even tries to tell you you don't, you need to remind yourself you are at the fulcrum over there and you are kind of balancing everything out for the patient. And you'll see a lot of times your patient will come back to have that conversation with you, Keith. Is my doctor doing the right thing? Like, am I on the right path? So you need to
Yes.
do that. So
I
that
think
would be my key thing
I'm
here.
so happy you all brought out these key issues. So thank you very much, both of you. Please be online as long as you can be. And now I'll request my friend Suki from Malaysia, Kuala Lumpur, one of the senior most experienced genetic counselor. Okay, a genetic counselor. She will now we are going to from which order we are going first. Suki will talk about Malaysia. And then someone will tell me, I'll just, and then they one by one. Can someone read? Malaysia, then Oman, Dr. Abir, and then UK, Australia, then US. Okay, they would have woken up by then. Okay, thank you. These are not pre-recorded talks, these are live talks. That's why we had to sort of juggle with this. So please.
Thank you so much, Rajiv, and so lovely to see old friends and to meet new ones. Thank you for the invitation to speak here today. Congratulations to the new genetic counselors. It's so good to have new genetic counselors join the senior genetic counselors, because that's how we learn with mentorship, just like us, and how we have learned from our seniors as well. So I think it's really important to have this community, and I like the term community in practice. And all of us are now in a community, and it's so good to be able to learn from each other and exchange ideas. So India is always very close to my heart, especially Tata. I hope I can get there again. I didn't manage to go this year because I was sick. Well, I'm going to talk a little bit about following on from all of the really good talks earlier on. What happens here in Malaysia as a country in Southeast Asia. Next. So it's very similar. I mean, listening to the issues that were brought up earlier, I think many countries in Asia especially have similar issues. So Malaysia is multicultural as well. We're way, way smaller than India. We're only of 34 million people. But we do have many ethnicities, which means we do have many languages, and we do have many different religions that are practiced. Next slide, please. So this is a map of Malaysia. We have two parts, the peninsula, which is West Malaysia, and East Malaysia, which is on the island of Borneo. So in terms of what is available in the public service, and Malaysia is very similar to India in that sense, we have a national health service. So there are only three main clinical genetic services, and they are located primarily in three large cities, which is in Kuala Lumpur and Penang in the north. We do have some services in the university hospital, and even though that is government, it is under our Ministry of Higher Education. And in terms of private, there are many private hospitals that are starting to offer cancer genetic testing, but there are very few genetic counselors to provide the counseling in this private sector. So we do have a non-profit like Cancer Research Malaysia, for example, where I work, and we also serve patients nationwide. We do a lot of telegenetic counseling. Now, what I want to describe here is that the lack of genetic services and the lack of genetic counselors have always made access incredibly difficult. So we need to think of newer ways. And for example, like what Prof. Rajiv has done is to train cancer genetic counselors. That is also something that is ongoing, but we have some nurses that do these short courses and are able to support the cancer clinics. So whilst we are training more genetic counselors, we do have a local university masters in genetic counseling, but that will take time. So we look at other alternatives on how to improve access. Next slide, please. So cost is a very big issue when it comes to genetic testing, I think, in our part of the world. Whilst we have local capabilities of doing the test, but it is still very expensive because every other thing is imported. We import all of our raw materials, all of our the machines, everything, sequences are all imported. So even though we have local testing capabilities, it is still expensive, and it's a numbers game. If we don't do enough, the cost per test will be high. But to get more people to test, more people need to be able to pay for it. So because we are a health service, we do have an annual health budget for genetic testing, but it is not allocated by disease area. And most of you who work in other disease area will realize that there are more pressing, urgent cases that requires testing. So most of the time, prenatal or pediatric cases will get the funds first, and very little will be left for cancer genetic testing. In the government service, we can get access to the free testing, but only for BRCA1 and BRCA2, not the other genes, not for Lynch or any other tests, because the government laboratories are only able to run the BRCA1 and 2 testing. So that makes us quite far behind in terms of testing in the government sector. So what happens is to become, so we look at more ways to be able to pay for these tests. And just like what Dr. Parna had said just now, we look at, as genetic counselors, we look at other sources of funding. So we look at charitable bodies, we look for projects, research projects where we can put our patients in clinical trials so that they will be able to have the test done via different routes. In the private sector, most of the patients are higher middle income or high income, then they would have medical insurance, private medical insurance. But medical insurance in Malaysia does not pay for genetic testing unless it is for a specific treatment purpose. So you can get a BRCA somatic test, for example, in ovarian cancer, or a HRD test if you are looking at PARP inhibitors. But most of the time, they do not cover germline or for any sort of risk management purposes. So we are unable to use medical insurance for that. On the flip side, many would not even want to use medical insurance, even if they could, because of the fear of discrimination. Next slide, please. So in terms of trying to understand how can we work better with the government so that we can have some ring fence funding for genetic testing. So we did a study, and using ovarian cancer as an example, we looked at willingness to pay. So we're trying to look and see if there's policy of which we can persuade the government to provide some co-payment. So we want to know how much are patients willing to pay out of pocket, even in the government sector. So we found out that actually more than half are willing to pay, but they have a median price of about 250 US dollars. So in Malaysia, we are unable to get any test done for 250 US dollars. It is about 400 to 500. So we know that there is a gap, but if we can find some way to top up or have some subsidy schemes, then we should be able to reach more people in terms of a shared cost or a co-payment type of system. Now, in this study, it was very interesting. In the end, it only turned out that 17% proceeded, even though, 58% say that they will pay, right? But the actual test uptake was only 17 because we then realized and we got the information through the interviews. That cost is not only the factor that prevents or is a barrier to taking up a test. There are many other factors, including social stigma, fear of genetic discrimination, and just whether or not they want to know. Very basic thing is they will say, we just don't want to know. Next. So to improve the access, as I've said just now, we look at different ways of delivery of genetic counseling. Telecounseling became more apparent after COVID. And in Malaysia, we actually are probably the highest users of smartphones in the region. So per person in a population is 1.5 smartphones. So there are many people with more than one smartphone. And why we know this is because we looked at the usage of WhatsApp. In our population, 75% of the population uses WhatsApp. So this was one a characteristic of Malaysians which we could tap into. So we developed more telecounseling processes and to be able to do more online or video calls. We also looked a lot at mainstreaming. So we have a very good group of oncologists and surgeons who are trained for pre-test counseling. And this is mainly in the private sector. So they do order the test and we do post-test counseling, which is by the genetic counselors, especially if it's a positive result with a pathogenic variant and requires cascade testing or the understanding of a variant of uncertain significance. So this also has been very successful in Malaysia, but it is clinician dependent. So there are some oncologists and there are some surgeons who are very keen, but there are some who will just say that they would rather refer out because it takes too much of their time and they feel that they are not able to provide good psychosocial support. So there are many in a cancer space that still would like a genetic counselor to work with their patients. The third category, which we are actually getting a little bit worried about, is whilst there are many local labs that have gone into the foray of doing sequencing, many are not well established or accredited to do a good diagnostic report. So there are many cancer genetic tests that are sold direct to consumer, usually through wellness centers or pharmacies. And we have been seeing more and more healthy individual with high-risk pathogenic variants that have come to us, of which we need to redo the whole process and work with them. So this is something that I guess also in many other countries that perhaps more regulation are needed when it comes to the sale of diagnostic testing and what direct-to-consumer testing can be used for. Next slide, please. Thank you. So we talked about access and cost, but what about the barriers? So in Malaysia, the biggest barrier in the private sector is insurance discrimination. We do not have any moratorium, and there has been more and more cases reported of which insurance are starting to request for a genetic test if there's a family history. We don't know where the law stands with that. And that is becoming more and more worrying. It's a trend because if someone has a hereditary risk, they would avoid the entire medical insurance of the person. So this is a very big issue, and many conversations are coming up. Ethicists are bringing this up to revamp the regulation when it comes to medical insurance and the legal position of how much an insurance can know about a person genetics. The healthcare cost overall is increasing because again the increased cost in the government sector has made queue and waiting time to be longer, so more people are turning into the private sector, but most of it are reliant on private healthcare. So the fear of losing a private healthcare insurance is so great that it's prevented many high-risk individuals from testing altogether. So they would rather get it and then be able to pay for the treatment than prevent it because they are so scared that they will not be able to get any payout for the treatment. So it is a very sad situation because we know that in high-risk individual, we can do something about prevention and risk management. There is also an attitude in our population which is not different from you in India. But we call it something like it is a term, it's called a fatalistic attitude, or rather a subscription to what is already decided on by a higher power. So in the many different religions, not just one particular religion, what is meant to be or what you're born to be is widely is widely believed. So knowing or not knowing them doesn't make much difference for some individuals. And this is something we need to understand a bit more and see how we can actually work around it. There was a group that worked with some religious leaders, and when the information came from the religious leaders in a different way, to say that you also need to take God gave you your health, you need to also take it in your hands and do what is necessary to help yourself. So when it came from a religious leader, then the uptake was a little bit better, right? So we as genetic counselors do need to understand where some of these barriers are formed, and some of it they need creative ideas on how to reach our patients better. Next slide, please. So I just wanted to summarize and to end that I think we have more similarities among Asians especially than differences. And I think we would all benefit from being a community together. I think genetic counselors are unique, and we have, we learn certain skills that will help us to be able to work with our patients. So in a way, I feel that it is actually a very powerful position that we are in, of which we have to be always very mindful and always very careful, because what we say can change the perception of someone about their risk, but may also, cause more distress if we are not careful with how we provide our genetic counseling. So thank you so much for your attention.
So thank you very much. You can stop screen share. So Kay, as expected, you have given a wonderful talk, and you brought out issues in Malaysia and the cross-cultural things and so many. And I think how the community of genetic counselor across they work together. And it's a very important message, I think, for the next generation of genetic counselors who are working. I'm sure many of them will be working in different parts of the world. Wherever they work, they will deal with these kinds of issues. What you said about the insurance companies prospectively asking, that was very sort of unusual. I had not expected that will be happening. And Vrinda was sitting next to me. She said even in Australia, they are asking, sometimes. So how when did this start? This is a more recent thing?
Yeah, it's a more recent thing. In the last 2-3 years, we started seeing requests from insurance for the patient to do a genetic test. But because the laws are not clear, so the insurance basically can ask whatever they ask. So what happened was that if you do not proceed with the genetic test, then they will not pay for the treatment. So that is now being brought up into a legal tussle. But is an actual example,
Call
and there
for
was more
action.
than one occurrence. Yep. So in all of the small fine print in the policy, it does say that, the insurance can ask for additional testing and additional information. And because it's silent on how much can you request for, right? And because genetic testing now is so available in a sense, they are starting to look at it. So it is a terrible situation for someone to be in. You test and they have a reason to ask because it's a high risk individual, it's a young patient,
Yeah.
high risk cancer with family history. The chances of picking up something is high. So, and they know that, right? But the moment they pick up something, it is considered hereditary, then they have a reason to void the
I think I'm
even
getting an idea. In few months' time, we will have a half-day workshop just to deal with this aspect. It's a very
yeah,
important thing. We can't just sort of, ignore it. We will have, sometime early 2026, we will have a half-day workshop just to deal with this aspect, and all of you would be there. So thank you, Suki. And
Thank you.
now I have the pleasure of inviting my friend, Dr. Abir Al-Saik from Oman. She works as a medical geneticist trained in North America and works at Sultan Qaboos University or Hospital in Oman. Thank you very much. Please, Abir.
Good evening, ladies and gentlemen. Thank you, Dr. Sarin, for this invitation. I would not have missed it. We had really amazing talks earlier, and they made my life very easy, especially Suki at the end. I will start by saying that I will start with the last statement that she gave in her talk by saying that our similarities are actually much more than our differences. Even in countries that are known to have resources, we actually still share the same challenges and share the same struggles. So I have actually moved to this new building. I just thought I'll share it with all my friends and colleagues here. So now I'm directing the Sultan Qaboos Comprehensive Cancer Care and Research Center, and we belong to the University Medical City. So what I will do is, you have given me really a very challenging task, is to talk about the perspective and the practice in the Middle East. So what I will be doing is, I'll be giving you a flavor of what's going on, like a general theme. The Middle East, as you know, it's really a very difficult word to define. That's what we are brought up to understand nowadays. Even the number of countries, actually, they are known now to be 22 countries. And you must know that it actually includes really, big regions and very different people from even different continents. So if you use the word Middle East, you actually include 22 countries. And that would, next slide, please. That would include countries mainly of the Arabian Peninsula, like Oman, Qatar, Saudi Arabia, Yemen, United Arab Emirates. It also includes countries in the Levant, like Syria, Lebanon, Israel, Jordan, West Bank, Gaza Strip, and Iran. And if you include the MENA region, when you include North America, that further includes more countries. And I'll be, talking about, the theme in general, but I'll be also focusing about the situation in Oman, because I'm currently in Oman right now. But so I would actually concur with the previous statements that were made by my colleagues. Although we come from GCC and Middle East countries, which are actually known to have an abundance of resources, an abundance of oil, as you know, we share actually the same issues shared by all of my colleagues so far from India and also from Singapore. So Oman and Qatar, I will be focusing more on GCC because that's, where I come from, but I'm happy to answer any questions if you have on the other Middle Eastern countries. So Oman and Qatar are very similar actually. Next slide, please. Oman and Qatar, we are very blessed to actually have the cancer genetic services within the cancer hospitals. And I'll give you more about Oman, perhaps in case people don't know, a lot of information on Oman. So it's actually in the southeastern coast of the Arabian Peninsula, and it shares borders with many other countries. It's very cosmopolitan. So people actually come to Oman, we all look different, we behave differently. There are people that actually originate from actually India, people from Iran, people from Pakistan, some people who are, nowadays we are allowed to, we have a green light to marry from other countries, unlike 5 years ago. So it's becoming very cosmopolitan. And this is why I think congratulations to the cohort that got graduated today. And it's our duty to understand all these different variations, to be able to help our patient to come up with the shared decisions that they need to make, in terms of management and so on, and screening. In Oman, as well as all the GCC countries, actually, 2/3 of our population are youth, so very young people. I mean, my grandmoms from both sides, paternal and maternal, they have really passed away very early. So most of the medical services, and that actually, we are very fresh when it comes to having tertiary hospitals. So most of our hospitals, actually big hospitals, were established just 40 years ago. The majority of the GCC countries and the Middle East countries, they are based on having a public health system. So the majority of us actually have all these services provided for free. Next slide, please. For free by, the health system, which now we feel has become a burden. And this is a very good slide. I just thought I will, this comes from a paper that was published by Khalsa, who is actually the first Omani genetic counselors. In Oman, we have very few Omani genetic counselors, and this paper actually shows the numbers that provide genetic counseling. So in Oman, the counseling is provided by basically 3 main hospitals, all in Muscat, all in the capital. So if you live very far, again, access is difficult unless you get referred to the 3 main centers. So it's provided by the Sultan Qaboos Comprehensive Cancer Care if you have got family history or personal history of cancer, or the National Genetic Center, which is attached to the Ministry of Health and the Royal Hospital, or to the General Hospital, which is attached to the university, and that's it. And in fact, the profession in Oman is still struggling to actually get the licenses and the recognition that they deserve. So you're very lucky actually to have all that in India. We are still struggling, and that's because of the really small numbers that are available in the country. Next slide, please. So we have 2 government tertiary hospitals that provide cancer genetics. Now, once this cancer hospital was established, or the cancer center was established, we are automatically now considered the national hub to see all the patients in the whole country, actually with family history or personal history of cancer. The other National Genetic Center, they actually cater for, you know, the pediatrics cases, as well as all the other cases, for example, prenatal, neurogenetic cases, and of course, metabolic cases. And we only have one private clinic in the country with a private laboratory, but that you would have to pay from your own pocket, actually. And the service is not covered to everyone, so only Omanis, if you're an Omani citizen, because unfortunately it's still considered as a luxury test. You get it for free if you're referred and you go to one of these main tertiary hospitals. Whereas if you are non-Omani, unfortunately, you would still have to pay from your own pocket to cover the testing. Now, we do have insurance in the country, but it's only provided for people who are in really very selected high-profile oil companies and other companies that can offer to Omanis and non-Omanis insurance policies. Having said that, some insurance actually plans do not cover, so it's very variable. So even if you have got an insurance plan, you still struggle with actually doing genetic testing, and we share the same pain, just like our colleagues that they have mentioned in the previous lecture, that actually these insurance companies, they are now only providing it if there is a therapeutic implication for doing the test. Like, for example, if you need to give a PARP inhibitor, for example, or, you know, the physician writes a letter back to the insurance company stating that the care and the management will be different for this patient. And even with that, sometimes they refuse to actually cover the screening that comes after it for the affected individual and the family. Predictive testing is also provided by these mentioned hospitals in the same big hospitals in the capital. And what's interesting in the GCC, and also in the majority of the Middle Eastern countries, we also, unfortunately, because of the increased percentage of consanguinity, which reaches up to 60%, we actually end up seeing couples that are at higher risk of having an offspring with homozygous BRCA genes. And as you know, the geneticists in the room would know that if you are a carrier, if you have homozygous BRCA2, you end up with a totally different syndrome, which is called Fanconi anemia. And we have got, unfortunately, also many cases with constitutional mismatch repair deficiency syndrome. And that's when two Lynch partners actually marry. There is a 25% chance. And this is a whole topic on its own. I'm happy to present it in future. And we, unfortunately, because of the inbreeding and because of the consanguinity, we end up seeing these pediatric syndromic cases, and within the hospital, including TP53, which is very rare. I don't think it's ever seen in other countries of the world. In Oman, we have families with homozygous Le-Fermini syndrome, which is on its own a very nasty syndrome, but two parents, actually the couple both are carriers, you have even a much more severe cancer syndrome that actually starts even before the age of 1. Next slide, please. So not only we do the predictive testing, but we also, in the cancer clinic, we also do it as a premarital testing, so that, you know, the young couples, they are informed about their offspring risk and the cancer's risk in their future offspring. So now, because we are shifted to this Sultan Qaboos comprehensive cancer care, in the olden days, which was only 4 years ago, we used to function from a general genetics clinic, whereas now in Oman and also in Qatar, I believe that we are the only 2 GCC countries where we are actually functioning within the cancer hospital. And in my point of view, this is the best model. The counselors have to be just like anybody else. They're as important as the medical oncologists, radiation oncologists. In the cancer center here, ever since we started, we actually have the genetic counselor as one of the very important, precious team member that joins the individual multidisciplinary team in each meeting. So we do have our own department, administrative department, the cancer genomics. but the same counselors, actually, they are within programs. So when we say program, so basically they are a member in the breast program, and within the breast program, they actually, when they discuss the cases together in the MDT, there'll always be a genetic counselor available when the patient comes to see patients within the program. So we have these virtual programs, functional programs, as well as the department. Next slide, please. We are very actually blessed to have this, but unfortunately, now we are reaching to a point that we are struggling with access because we have become national. Everyone now in the country has been getting in touch with us. Anyone in Oman with family history or personal history of cancer can actually, contact the clinic via WhatsApp, via website, and actually get this for free if they're Omanis. If they're not Omanis, unfortunately, we try to help them by, giving general counseling on the phone. The moment they come in and step into the cancer center, unfortunately, we will be asking them to pay for the consultation. So this was discussed. So all Omani citizens have no problem. They get it for free. Minority get it through medical insurance. And in-house, we only offer BRCA testing sequencing, and we outsource for the cancer panel testing. And now, after getting the CAP certification last month, we are actually now planning on developing the panels in-house so that we stop sending the samples to abroad, and that's going to be major. I think this will be really very difficult to convince Ministry of Finance to actually convince them to finance this and do the full cancer panel on the patients that we see here in the. So just like all my colleagues have mentioned, that unfortunately the thinking is it's still being considered as a luxury test, and to convince the government, even in a country like the Middle East, believe it or not, it's not easy. It's not easy. So the cost for the panel, actually, it's $500 if we request it through the cancer hospital here. If we do target testing, then that would be between $150 to $200. And if patients are paying, sometimes they go to the private clinic, and what we do is sometimes we cheat and give the consult. Please don't document this. We do the counseling on the phone and then ask the patients to go to these private clinics, so the private labs, so that they just do the testing. And similarly, it's still expensive for some patients, and they would still go and pay the $200 for the test. Of course, once we know that the patients actually are not Omanis, we also give them that advice that they can, go and get the test from their own countries. But then we come to know that even within their own countries, except for few exceptions, they will have to pay for it from their own pocket. So we discussed this in the past. So access is through programs, cascade testing, of course. We have made it very easy to, the affected individuals, once they spread the information, it's very easy to contact the team to actually bring in your other family members that are at risk to do the testing. They can contact us through social media or website, and we are always happy to see them. And we have no problems with that, with a turnaround time of about 6 weeks. Of course, the barriers are distance. Patients from the south, believe it or not, so we have so we have the southern region in Oman. They have to actually travel by plane to come and see us, and we are trying nowadays to convince the Ministry of Health to actually, try and counsel them via telehealth and try and agree with them on who actually pays the bill. Is it the university hospital, which we are located at, or is it the Ministry of Health? So most counselors are non-Omani. So now the issue. So now that we only have very few Omanis in the field. So we keep the trainees with the, very expert senior non-Omani counselors for translation. And we have this plan of opening up the master's program by next year, so that we are able to train Omanis to actually be able to give the information. We have got a lot of research and literature on this, where even the most educated people that actually are very fluent in English would still prefer a Omani genetic counselor, someone who actually talks the same language. Next slide, please. High-risk families, we have no problem. They usually get referred by their family members. And so that's not an easy task, doing the testing. What we struggle with actually is the screening. So executing the screening is a big pain, especially now with increasing numbers at the cancer center. We're actually unable to provide the same screening that we used to provide with the stated turnaround time. So we share the same pain with our colleagues in India and Singapore. The number of genetic counselors, as we have mentioned, in the cancer center, we only have 3 genetic counselors and 2 physicians, 2 clinical geneticists, and they are for the whole country. Consanguineous rate, we actually discussed this in the previous slides. The majority are actually referred back now because we cannot provide the screening in the cancer center, because now the cancer center resources are only protected for people who are diagnosed with the cancer. Risk reduction surgeries are offered at Sultan Qaboos Comprehensive Cancer Care and Research Center and the Royal Hospital, but the uptake is really low, and that's a whole topic on its own, that actually people still consider it as, you know, a procedure that I don't need to do. And due to, you know, thinking that why would I do something at this point when I would never, you know, develop the disease? We have major issues when it comes to this, even within, again, the most educated people, even with risk reduction surgeries for the risk for ovarian. We still have people, and we have literature on this, that really struggle with the body image issues, even if you do it laparoscopically, and even if you do it without a scar. And now I actually here in Oman, it's the other way around. So if it's a female that get diagnosed with one of these high risk mutations, we actually found that the women actually are very powerful. They bring the whole family, and the opposite is true. Once we diagnose the men, they actually fly away and information does not get spread. Having said that, the younger generation is totally different. We have noticed that in the past 5 years, the number of men that have come to the counseling clinics are much more higher compared to 5 years ago. Next slide, please. Our culture, as you know, it's super protective. It's very tribal. So even in the most educated families, you really, you know, find these very tribal powers. There is always someone that controls the tribe. And even in the most educated nuclear families, the couple would go back. And when I say couple, because that's always the most complicated part of it, is when both husband and wife have the mutation, but they always go back to, you know, the father figure in their own families. Decision, unlike, you know, the West, is really made by the whole family. And some couple decide to withhold information if they are not related to each other, and that is to prevent interference from the rest of the family. We share the same pain of fear of stigma, and I'm not proud of this, but even in our, you know, hospitals, there is really problem with really protecting privacy, especially if you're a health worker. If you're a health worker, people know when you are diagnosed and your stage before you even know about your diagnosis, unfortunately. Carrier status, again, 70% so this has improved in the past years, where actually in Oman, 70% of the young couples, especially, and it will be very interesting. Actually, we are having this as a research idea to see, like, what is the difference between Z generation and Y generation? Like, is the generation now, the younger generation, is their uptake of doing the carrier testing higher? As an observation, we do think they are different than our generation, and this will be very interesting to look at all the Middle Eastern and also the Asian countries. Pre-implantation genetic diagnosis is supported And we can refer couple to the National PGD Committee. However, pediatric patients and prenatal, if you have a diagnosis of Tay-Sachs or a diagnosis of a metabolic condition, they always get the priority. So we struggle even with that. They're always down on the list, and there will only be very few people who get it approved. Next slide, please. So there is a lot really to discuss and share, but for the sake of time, I'll just say, to all these youngsters that have graduated today, that genetics, although despite, mentioning all these challenges, it's really the science of hope. And you're very privileged and you're very lucky to actually live and work in this profession. And we all know that in the future of healthcare, genetics won't be luxury. It's not optional. It's actually essential. I always tell my students and colleagues that the day will come, I'm not sure when, where a genetic testing will be treated just like a hemoglobin level or a glucose level. So thank you very much again, Dr. Sareen and colleagues, for sharing our experience. I'm happy to reply to any questions that the audience may have. Thank you.
So thank you very much, Abir. Such a powerful speech you gave. The words that you said really are moving. And I think it's such an inspiration for youngsters to understand the field they have chosen. And it is so important, the points you said. And I think we can see from Australia to from Malaysia to now in your place, so many differences. Within a country also, we know in India, within a country also, different parts, so many differences you see. And a genetic counselor, a genetics professional has to cut across that and go to that. So hopefully, as you said, maybe the younger generation is probably better sort of adapted to it as it was in your parents' generation. Your children's generation may be much better. And sometimes the rate at which the things change can actually surprise us. So I hope it is in the right direction, not in the wrong direction. So any question? Ariba, you have worked here in India. Now you are in NHS, England. And you heard in between you were where in Middle East you were there, Ariba? I forgot.
I was in Dubai, but I didn't do much work over there.
You didn't do much, but you would have observed. So what Dr. Abir said, did it sort of, you understand that, what is there? So
I think
ask her any question or comment.
I'm really pleased to see how much things have evolved, because when I was there about 4 or 5 years back and was trying to get integrated into the healthcare system, there weren't many opportunities for me to even kind of be integrated in it. So to see that you have such a nice facility and you have genetic counselors on your team, it's really refreshing and gives a hope even to us as professionals that things are moving forward in every part of the world and things are accessible to patients.
And mind you, Ariba was trained with us, and then she then had masters in Manchester University in genetic counseling, and she was there and she was not getting a job. So thank you, Abir. I hope, and I'm so happy to see how your efforts, I mean, you have been coming and talking, giving talks with us for the last 7-8 years, and I can see how the things have progressed. So all the best to you, Abir. So if you can still be around and listen to the other talks. So now I'm asking Ariba to talk to us. So she knows what India is. She started a genetic counseling career. I was actually my lab girl. I said, you want to try counseling? She said, okay, let us go in there. And she liked counseling so much that she became a genetic counselor. And I think I can make out within few months whether this person will always be a genetic counselor. And I predicted, and she is. It's now, so many years, and she has trained herself extensively. And she will tell us about the UK perspective. And UK is very cross, there are a lot of all cultures exist in the England. Please.
Thank you so much,
Your
Dr.
time,
Salim. Okay, can we go to the next slide, please? So in a way, if we see, every genetic test is a story of.
So Ariba, you are the co-host. If you want to change your slide, you can change your slide, I think.
I don't think I'm able to.
Okay. That's all right.
Yeah.
Then.
Thank you. So like I was saying, behind every genetic test, there is a story of uncertainty, hope, and a choice. And as genetic counselors, we fall at an intersection of science and humanity. And we kind of take our patients and families through a process that can sometimes be quite complex and emotionally challenging. And hopefully, through my talk today, I will highlight a few ways in which in the UK we try and make this process fair and compassionate and accessible to everyone in the general population. Next slide, please. So we'll go theme wise. So we'll go to the first theme about what is available in the United Kingdom. What does it cost, and if there are any barriers, and how people can access genetic testing and counseling for inherited cancer conditions. Next slide, please. So within the UK, there's quite a structured framework through which genetic professionals provide their care and services. We have 7 genomic laboratory hubs across the country, and within those hubs, there are 23 regional genetic services. And just to give an overview, each of these genetic service and every professional works through the guidance of the guidelines that are set in place by working groups like the United Kingdom Cancer Genetics Group, or through the GCRB, which is Genetic Counselling Registration Board. And there are quite a lot of eligibility criteria for who we provide, what we provide, and we'll go through all of that. And it's quite a streamlined process compared to what we've heard from a few other countries. Next slide, please. So this is just to give you a diagrammatic representation of what the 7 GLHs look like. Where I work is at the bottom right in the southeast GLH, where Guy's Hospital falls under. And there are a few other hospitals that may fall under under that service. Next slide, please. So if we look at kind of what all is available to patients, so obviously these services are provided in the genetic testing aspect, and as well as the clinical aspect, which involves assessing risk, assessing genetic testing eligibility, providing genetic counseling for those things, providing post-test counseling, providing management plans, and also taking people through management for any risk that they are at. And we have a routine pathway where a person who is at risk of an inherited condition or has had a cancer in the past, and their oncologist or GP feels that they fit under a referral criteria for an assessment from the genetics team, they will refer them to a genetic service, who will then take their personal history, family history, and assess whether they are eligible for testing. Sometimes people are eligible for testing, and sometimes, when I say eligible for testing, usually we would test someone if there is a likelihood of more than 10% of finding a mutation. And if the likelihood is lesser, we would give them counseling and reassurance, and risk assessment and screening, if any, based on that risk. So that is the routine pathway through which we take people through. There's also a rapid pathway. So, like, for example, if someone is currently undergoing cancer treatment, and genetic testing will impact their surgery or any chemotherapy influence, then they are to be seen within 2 weeks of being referred to the genetic service. So that's the rapid pathway, and their genetic testing is also done on an urgent basis. So routine test can sometimes take about 6 to 8 weeks. Sometimes you can get it back sooner, but a rapid test, the lab has to turn it around within about 2 to 4 weeks. Sometimes, if we request the lab, if they have the capacity, they may give it to us sooner. So that is where we liaise sometimes with the oncology team and the lab team, and kind of see how we can expedite things so that the treatment is not impacted for the patient. Within the services, like I said, there are a lot of specialists, healthcare professionals, but we also have in the back end a lot of admin staff who are patient pathway coordinators or patient access team who help us procure information from other centers. So, for example, if we have consent from a relative to access their records, then we can request for their records from other hospitals if we need to, look into more details about their cancer diagnosis, or, if we need the genetic test report to provide predictive testing. The kind of panels that the UK provides is slightly different from the larger hereditary cancer panels that are there, say in the US or Australia or India, because the panels are divided into subgroups. Say, for example, the breast and ovarian cancer panel, or the Lynch panel, or the renal panel, and each panel will have different set of genes. And each of these has a different criteria as to when someone would fit into being eligible for testing for that panel. There is more information on the NHS website, where if you just look into NHS genomic test directory, there's an eligibility criteria. If you're interested, you can go through that as well. Next slide, please. So how does a person reach a genetic service? So like I mentioned, they are referred to us either through their GP or the oncology team. And even in the, for example, in the breast or the colorectal cancer teams, there are a lot of nurses who do family history work, where they will take family history, and if they fall into the eligibility criteria to be referred, they will refer them to us. There is quite clear guidance throughout all the GLH, and the pathways are very clear, although there's still some professionals who may need some further training, and there's still limited knowledge, and there might be referrals that are missed. But essentially, it is through the GPs and oncology teams that will refer. We are kind of moving a lot towards mainstream testing. So if someone is diagnosed with a cancer, then the breast care nurses or the colorectal nurses are being trained to provide genetic testing to the patient if they are eligible and don't really need that much assessment with family history. For example, if someone has had a triple negative breast cancer below 60, or if they've had a breast cancer below 45, and a close relative with breast cancer below 45, or for example, if someone has a colorectal cancer below the age of 40 or 50. So depending on what the clinical indication is, sometimes the oncology nurses are also trained to take consent and take people through genetic testing. If anyone is found to have a mutation from that test, they are then referred to the genetic service for a further discussion and to ensure they are put into the right pathways for screening and management, which I will discuss in a bit. Next slide, please. So with respect to testing for family members, is pretty similar. Whenever we see a patient, and with every consultation we give them a summary letter, and if someone has a genetic test mutation positive result, we obviously give them a report, but we also give them a to whom it may concern letter, which will have a hospital number kind of identifier for our patient without their name and things. So they can pass that to their relatives, which they can then use to get a referral to their GP, through their GP, and then can access testing. And the whole beauty of the framework is, so if someone is tested in the north, in a genomics center in the north, and the relative is in the south with us, we can always contact the team in the north and say, do you have consent to share the report? Can you share the report so that we can provide testing? If they don't have consent, then we will coordinate and send the forms that through which they can get consent from the relative. Sometimes it can be challenging if there is not much contact within the family, but we try and find ways of how we can procure information, keeping in guidance with data protection and confidentiality as well. And so in a lot of the times, apart from just the counseling, we're also doing a lot of back-end work to ensure that people get what they need, and they have access. Everyone has access to a genetic test, that they are at risk of, if they're at risk of having a mutation. And one of the key things I found is helpful is to maintain, a lot of documentation is maintained within our service for every patient. And sometimes it's also helpful when we have to link up people. And, we've had instances where we've had a brother and sister referred and whose parent we have seen, but they may not have, if they don't have the correct identifiers, we may not be able to link them up. But if once they give us their parents' information, we can look them up in our system and then link them up as one family, instead of having 2-3 different families from the same 2-3 different files for the same family. So sometimes you have to do a bit of detective work as well. But yeah, so cascade testing is usually offered within the NHS as well. Some people, if they want, they can access it, both routine testing and cascade testing privately as well. Next slide, please. So with respect to cost, it is genetic testing and counseling is funded by the NHS, and most people will access it through the NHS. Some people might not want to wait, or they have private insurance and they want to get it done privately, so they can access this genetic testing privately as well. Testing can cost anywhere between 250 to £1,000, depending on the provider and the company. And consultations for private testing can range from 250 to £400. In the private setting, so there are about 330 genetic counselors within the UK, but most of them work within the National Health Service. There are very few who work privately. Cancer genetic testing and counseling provided privately is mostly done by the consultants who work in private hospitals. Genetic counselors who provide private testing are usually linked to private genetic testing labs. And predictive testing, like I had said earlier, can also be accessed privately. It is slightly cheaper, obviously, but the consultation would probably be the same. Next slide, please. So moving on to the next theme, thinking about screening and management, and also risk-reducing surgery. Next slide, please. So as a part of the structured framework for management, we have multidisciplinary teams who manage anyone who have a mutation. Now, one of the other programs that we have is a National Health Service cancer screening program. This cancer screening program is, there are two aspects to it. One is when people generally have screening, like, for example, anybody can have breast screening from the age of 50, which is 3 yearly mammograms. But then for people who have a very high risk because of a mutation, or even because of their family history, there is a very high risk screening program, and each region will have different centers that provide very high risk screening. So when someone has a mutation, we from the genetic service will refer the patient along with a copy of the report to the very high risk screening service. And then that service, based on the patient's age, will call them for the appropriate screening, and will send them letters for appointments in a timely manner. Sometimes people may not have a genetic mutation even after genetic testing, but they may have a higher, family history. I think Dr. Aparna spoke a little bit about, it was, I think, Vrunda who spoke about CAN risk and risk assessment. So that is another model that we use as well. So if someone has a more than 8% 10-year risk between the ages of 30 or 40, or a 12% risk between the ages of 40 and 50, will be at a high risk and will be able to access very high risk screening, which is similar to screening that you would get if you have a mutation in a high risk gene. I think I've covered all of that. Okay, next slide. Thank you. With respect to lynch as well, there is a national bowel screening program. Anyone after the age of 50 can have a QFIT test, which is an immunohistochemistry test for bowel screening. For those who have Lynch syndrome, similar to the breast screening program, there is a national Lynch screening program. This is a fairly newer program. Earlier, we used to refer patients who have a mutation to their colorectal team, who would then arrange screening for them in a periodic manner. Now, patients who have a mutation in one of the Lynch genes are directly entered into the Lynch portal, which is a national portal, and then they kind of disseminate people into the regional screening centers, and they are invited, with appointment letters every few years for their screening. Next slide, please. Um, uh, I mean, like we've been saying, that there are certain things that can be quite broad when it comes to barriers that for screening or for surgeries and things. And Dr. Dipanjana mentioned about understanding, and it depends on how your patient understands information. And that is very, very vital in accessing and compliance to screening. It's also a little bit about how the genetic services coordinate with the screening units. Like, for example, if there's been a missed referral, or a referral hasn't gone from our end to a screening unit, or the screening unit has received it but they haven't kind of actioned the referral, then the patient is kind of lost in follow-up. So there are safeguards and measures in place to mitigate those circumstances. However, sometimes, rarely, people can get missed out. Then, in those cases, we also kind of leave a little bit on patient responsibility, that, they know they have to have screening, and if they haven't received some information, then they kind of get in contact with their genetic service. Some of the barriers to accessing screening could be that waiting time, because the NHS has a lot of workload in certain regions and in certain departments, and sometimes they can be a long wait to access screening. And sometimes, within a region, it might be a long travel for a patient to access. So if, they have travel issues, or if, depending on their age, or, their physical ability to physically go to the appointments. And as someone, mentioned earlier, there's also a fear of the process itself. And there can be several cultural and language barriers that may affect people complying with the screening as well. With respect to risk reducing surgeries, it is offered either through the oncology team. If someone is already undergoing breast cancer treatment, for example, and they have to have surgery, and if they have a mutation, then their oncology team can, at the time of treatment, offer them a risk reducing surgery and reconstruction if that's what they wish to do. Some patients might not want to have it done at that time, because it is a big surgery, or it may involve a larger recovery period, or it may not be the right time for the patient. In those cases, they may have surgery at a later time. Within our genetic service, we have a multidisciplinary team which runs a clinic called the Hereditary Breast and Ovarian Cancer Clinic, which has breast surgeons, gynecology surgeons, clinical psychologists, genetic counselors, and the research team. And all our patients who have a BRCA mutation, or a mutation in a breast and ovarian cancer gene, they are referred into that service, and they can access support through that service. So even they will arrange surgery for them, or they may refer them to their local gynecology or a breast team to access that surgery. And these are all funded by the NHS, unless someone wants to have have the surgery privately if there is a longer wait time. And again, compliance depends on a lot of personal circumstances that have been mentioned earlier as well in previous talks. It can also be influenced by people around them and how they perceive situations.
20 minutes are over.
Oh, okay. Sorry. I will come. I'm almost towards the end of my talks. Okay. Yeah. So there's a lot of support available, but also there can be quite different barriers as well. Can I have the next slide, please? And even the precision oncology, like the application of PARP inhibitors or immunotherapy, they are accessed through the oncology team, and depending on the genetic test results, we can coordinate with them and provide them the results, hopefully within a time frame to provide that um, uh, to be able to provide that care to the patients. Next slide, please. Next slide, please. And with respect to vulnerable people, Dr. Sareen mentioned this, so I'm not going to go into many details, but we do have a lot of different laws and legalities that are there to safeguard our patients who may fall under this branch. Next slide, please. Um, so one of the key things is to make sure that we have trained professionals who are able to identify these challenges and to support them within our counseling service. We ensure that we have informed consent, we assess capacity for individuals, and ensure that we are looking after the person individually, and taking care that there's no harm or anything being done, and involve support teams and advocates where necessary. Next slide, please. And like I said, the legal framework involves a lot of different acts that are there. There is a Mental Capacity Act that ensures that we assess whether someone has capacity to make a decision, and where possible, always ensure we go with a mindset that someone has capacity, and then help them be assessed if they do not, and take them through that process, and make sure everyone is protected and treated equitably and in fairness. Next slide, please. Next slide, please. Right. So just to conclude, that there are quite a lot of frameworks and that are in place to ensure fair and equitable, genetic testing and counseling to everyone who is coming to us. It's quite streamlined. It's slightly different from what we see in other countries. But having said that, there's still a lot of room for improvement. Like Dr. Sareen mentioned, there are people from different cultures and nationalities that are here, and sometimes languages can be a barrier here as well. We do use interpreters and things like that, but that can still be challenging in certain cases. There is a lot of guidance that we follow, but it may sometimes be necessary to think out of the box, and we do have an MDT that can make decisions beyond those guidelines if needed. Next slide, please. So just to end my talk with just saying that genetic counseling in cancer is not just about testing, it's about translating genomic knowledge, compassionate and equitable ethical practice. And I think we try our best to maintain that within the UK framework. I'm sorry I couldn't cover a few things, but if anyone has any questions or would like to know more, please feel free to contact me, and I'll be more than happy to share some information. Thank you.
So thank you very much, Ariba. And again, your last slide was very important and powerful. And just to show that in UK also, although they have a very well-developed system, but there are challenges in terms of screening people, in terms of wait list. Could be frustrating sometimes. As a genetic counselor, is it sometimes frustrating?
Like, I think what frustrates sometimes most is, for example, if we may have a relative who's referred for testing, but their parent has not had testing, and then their parent is referred and they have to wait another year, or even with screening, they have to wait for a long time. So it is frustrating, but I think at the end of the day, it is what it is, and we have to just,
I think
be
in NHS,
equitable.
you have to just accept what you get. You can't.
Because I cannot just bump up somebody because, I've come to know of them. There might be someone else who's been waiting as well, so we have to treat everyone with fairness.
Yeah, I think that's very important. So thank you, Ariba. Now we'll have, I requested Vrinda to shorten her talk to 10 minutes Australia, because a lot of things were similar. And then after that, Srika from US, East Coast. Please. Want to take the mic?
Yeah. Hello, can you hear me? Brilliant. All right. So that's where I'm going to speak to you from. My talk is going to be very similar to what Ariba has shared from the UK, because Australia is a British colony and our healthcare structure is very similar to what there is in UK. Australia says that it has one of the best healthcare systems in the world, and I do agree to parts of it, and I'll tell you why not. So I'll shorten it because a lot of things are similar to UK, but there are a few interesting things about Australia I would like to highlight, and also some issues that come with the counseling. So if we look at Australia as a country, it's quite big. And in March 2025, by our census, it said that Australia's population is at 27 million. So growth is due to combination of natural increase and net overseas migration, and that's increasing at 1.6% annually. The largest demographic group is young because we take a lot of migrants, and it's between 35 to 39 age bracket, and overall male to female ratio is equal. So that's a big country. And we do have Melbourne, which is Victoria, Sydney, which is New South Wales, which are very populated cities and states. And then Brisbane, where I come from, is Queensland. So when I looked at that, I was quite excited and I thought I'll put it in perspective. So where we stand in Mumbai, that's Australia. The current metro population of Mumbai sits at 22 million and 89,000. And if we were to compare how we look in the world, we are talking about a country that size at that population, and we are talking about a city of that size country, and that's one metro city. So we have a lot of things that are streamlined, but why they are is on the screen. So Australia has public health system, which is Medicare, which is Australia's universal health system, very similar to NHS. And the three major parts of this service are medical services, public hospitals, and medications, which are covered by Medicare. We also have the private health. So Medicare does cover costs of a lot of things, but it goes by triage, which is putting everyone in a line by urgency, and the wait lists can be long. Private health system, a lot of Australians will opt for private health insurance cover. So that will be hospital covers, and that will cut out the wait list costs for treatments. Some of them will have extras. So dental, ophthalmology, physiotherapy is not covered by Medicare, and private health insurance will cover that. And there are some private genetics clinics, which will charge out of pocket for genetic counseling as well as genetic testing. So there are very few genetic counselors in the private health system. When I practiced privately, I was the only one in Brisbane at that time. And in public, there are similar numbers to NHS. We would think we are about 200 genetic counselors in Australia. So the genetic services are funded statewide, and each state will have its own public system. But we have a governing body, which is the Human Genetic Society of Australasia, which encompasses Singapore, Australia, and New Zealand. And that is the governing body that does certification for genetic counselors, laboratory scientists, as well as geneticists. So that's the central body, and its sub-body is Australian Society of Genetic Counselors, or ASGC. And all of these states are kind of governed by Australian genomics. So while you will go to the Victorian Genetic Service in Melbourne and New South Wales in Sydney, you will still be getting the same rules that are applicable. So while the genetic services are owned by every state, the practices, policies, and access is national. So if I am talking about my practice, Genetic Health Queensland, if anyone is referred to us, we divide them into categories, and we do a lot of triage. So a lot of genetic counselor time is gone into looking at referrals and putting them in the right queues. So we rotate, and the day we triage, we don't get much else done. So we put category 1 that will be seen in 30 days, and that includes patients with treatment implications. So recent diagnosis of breast cancer, where testing will decide whether they have a bilateral mastectomy or they will go for lumpectomy and radiation. That will be seen by as a category 1 or within 30 days. So are pregnancies, or things like Stargardt disease in children where there is gene therapy available. So anything that would change the treatment course is category 1 for us. Category 2 is predictive test for familial mutation where there is treatment. So anything like BRCA predictive, cardiac genetics predictive, etc. will go as category 2. And the category 3 waits. in the amazing public health system. I have seen patients 18 months after they have been referred in. Some of them had forgotten that they had been referred in. So that's, I suppose, comes with the sort of access to genetic counseling and genetic testing. So in cancer genetics, very similar to what Ariba said, a lot of our time, apart from triaging, also goes in working out if the patient is eligible for public funded gene testing. So the baseline probability to offer public funded gene testing where there is no cost of genetic counseling or testing to the patient is 10% prior probability. And there are a number of tools we will use. And one of our resource, which I would really like to share with you all, is EVQ. So evq.org.au, that's the website that will have ways to calculate prior probability, lot of guidelines, risk management, and patient information sheets. So I'm just giving you an example, but we'll whiz through. So individual with breast cancer who meets the following criteria with pathogenic probability of more than 10%. So we use tools such as Manchester, CanRisk, and we have some pre-priority calculations. So triple negative breast cancer at any age, female between 51 to 60 where there is bilateral breast cancer or additional family history, etc. So there are very prescribed set of guidelines, whichever genetic service you go to will be used as. If you have ever used the Manchester score, it's a good tool to calculate prior probability, and that goes for affected patient, age of diagnosis, family history, and pathology. So you see the total at the end of it, it crosses the number 15, your prior probability is more than 10. So we have a few tools to look at that family history from a family history questionnaire to work out the prior probability. So very similar to what NHS had, similar in colorectal cancer or polyposis syndromes. So how is the journey of the patient looking like if you were in Australia? The referral is accepted and triaged. Then you have the intake appointment, which generally can also be a family history questionnaire. So we send out a questionnaire for the patient to fill in. They send the questionnaire and we put that pedigree into one of the softwares and can do CanRisk. The first appointment or pre-test counseling is very similar to what I have seen you girls do here. And that would be talking about the test if they're eligible. If they're not, under the public health system, we explain to them why that the probability of finding the mutation is low. And then they can go for private testing, or it can be risk assessment or genetic testing not available. And the second appointment or post-test counseling is result, patient letter, plus or minus the family letter, similar to what Ariba said, to distribution to family members, risk management guidelines, and information for family members. Follow-up is not done always, but it is done for high stress patients. If this was non-cancer and we were testing for something like HD or motor neuron disease, we would add that intake appointment as our first appointment. So we'll generally see patient twice, once to talk about condition, second time to review things, and then the test and the result. So those appointments will be a little longer depending on the condition in question. So we have spoken about a fair few of this, so I wouldn't repeat myself, but I'm going to talk a little bit about the genetic discrimination. And we spoke about health insurance, that was in the Malaysian setting. In Australia, there is no implications for buying a health insurance if you have a genetic mutation. However, buying a life insurance, applying for certain jobs, and in life insurance, the income protection part of that life insurance can get affected if you had a family history of genetic condition or you were undergoing genetic testing. So that data has been accessed by life insurance companies, and buying life insurance has been contested heavily. There is probably going to be a rule soon. There is currently a sort of a rule that says that you can't question someone their genetic status for an insurance under 5 million, the meritorium, but that may change into a law shortly. So kind of going through risk management was very similar to what Ariba has said. So I will leave that part, but I want to talk a little bit about some observations that I have had before I end. So I really thought that Australia, similar to UK, is a melting pot of various different cultures. There are a lot of migrants, people, white Caucasian population that has been living there, and Aboriginals that don't engage very much in the health system. So when we talk of culture and ethnicity, they're interchangeable words, but how people approach the healthcare system is very different. So the native aboriginals are very less engaged in medical system, and they are even lesser engaged in the genetic counseling clinics. So we have liaison officers that will kind of advocate for the aboriginal patient to come to the genetics clinic, but the engagement is poor. The Western medicine culture is much more autonomous. I find they appreciate the practitioner being very honest, communication being open, and their decisions are based on their own perception of risk. So I find that is the group that is going to really opt for something like preventative bilateral mastectomy. And that is probably the most uptaking group of that I really, really want to do something to reduce my risk. And that's going to be non-nipple sparing preventative bilateral mastectomy, and that's what I will go for. So I do see that huge difference in that uptake based on ethnicity. So different ethnic groups do seem to have different approaches. While if we someone like a migrant from India, let's say, or Middle East or Pakistan, healthcare provider is seen to be as expert, someone who gives them hope. And that's not so much a conversation, but there is that hierarchy which comes in. So I do find in genetic counseling session, depending on who is sitting across the table, you will have to modify your session slightly based on the beliefs on health and illness, faith as a guide, gender roles, marriage, and social discrimination. So Human Genetics Society of Australia will have a lot of position statements about how we practice, and they are available there. But what I want you to take away from today's session is how we develop our own practice. So language, a cycle of poverty, perspective of the family, how one views life and death generally. What is the role of faith in their coping mechanism? And are we non-directive, and should we really be? Should we be giving them 20 options of just do BRCA1 to BRCA2 testing, do the broadest genetic test, or should we be the one that are navigating and saying, would you rather not more, or do you not want to know too much? So being that shared experience. So I'll end with my own journey. And that's, as a counselor, what we need to do is develop a bit more self-awareness. In my case, I feel I'm a migrant. I bring my own set of values to every session, depending on the person who is sitting across to me. I want to be present. I want to listen. I want to be authentic, and I want to be empathic. And patient story is important for me to understand where they're coming from, because we may not have any shared experience. We did not do the same schooling. We did not go through the same, I suppose the music they listened to when they were growing up and I grew up, and the kind of experiences they had and what was normal for them in terms of dating and their reproductive choices is very different to mine. So their narrative is important, and that's the one that needs to be respected. When I'm presenting options like bilateral mastectomy, are my own biases blocking me? Am I just going through that quickly and saying this option is available for you? Or am I giving equal weightage to everything I put on the table because it's not my risk and my decision to make? And am I being aware of not giving equal weightage to anything? Because I do see that depending on the culture and how we are brought up, we may not present everything with the same weightage. Being aware of the transference and counter-transference. We do see ourselves in our patient a little bit, and that's not something I would have done. So I might not promote that to my patient. So being aware that whether I'm seeing a little bit of that, or this was a life experience I had and I behaved differently, they're taking a different decision, it's upsetting me. So being aware of what we see in that patient's narrative and what we bring, and do I change and modify what I say according to what the patient needs or what my experience is, and is our agenda mutually established? So I do see that when we talk about a vulnerable patient, that we have to have a reflective practice. We have to debrief with our fellow genetic counselors. Any case that was difficult, anything that was unexpected, kind of go through that and say why it was the way it was and value the team. That was it from me, and a bit of Australian and a bit of my own perspective. Thank you.
So thank you very much. It was a very refreshing, good talk, and I'm glad you shared your own journey. That was very important, your own perspective. So the last talk, and then we will just in few minutes, we will wrap it up. So Srika, Srika is, hi Srika. What time of the day it is now?
It is 8 a.m.
8 a.m. I hope you're not getting late for work. So,
It's a holiday.
it's a holiday.
Yes.
Oh, yes, it's a holiday.
So
Okay.
it's Veterans Day in the US. So
Okay, Veterans Day. And I woke you up early in the morning on the
that's
holiday.
okay.
Okay, so I'm so happy that Srika is here. Srika started her genetic counseling journey with us, I think 2017 or 19. Which year was that?
2018.
18, okay, in between.
Mhm.
And then she went ahead and did her master's, and she topped her batch. That was in which college? I'm forgetting.
Emory University.
Emory. She topped her batch of
Mhm.
genetic counselor at Emory. And she then worked for several years with cancer genetics, and she's just recently changed her roles. So, Srika, you must have heard what the previous speaker said. So, you please share with us the US perspective in 20
Yes.
minutes. Everyone is taking more time. I hope you will stick to your time.
No, I will stick to my time and I won't. A lot of people before me have put forward a lot of good points that I'll try not to reiterate. So if there's something on my slides that's already been discussed, I will move past it. Okay. I'm just waiting. There we go. Okay, again, like Dr. Sareen said, I'm a genetic counselor. I was trained in the US here after working with Dr. Sareen, and I worked in cancer genetic counseling for 4 years until recently transitioning. Next slide. I'm going to start by talking about the availability, cost, access, and barriers to these services. Next slide. The US is definitely one of the most well-resourced in terms of number of genetic counselors. As of 2024, there was about 7,000 certified genetic counselors, and about 30% of the CGCs work in adult cancer genetics. So maybe around 2,000 genetic counselors. But nothing, again, just like all the other countries, the population of the US is around 330 million. It is just like the UK and Australia, a melting pot. I have here at the bottom right, you can see about 60% of the population is white, 20% Hispanic, around 12% Black or African American, 6% Asian, and then other minorities. Among this 330 million population, we've seen about 2 million new cancer diagnoses in 2024 and about the same this year as well. But when it comes to availability of genetic counseling services, we know a lot of these services are in metropolitan and urban areas or academic center areas. But compared to other countries like the UK and Australia, we have a healthcare system that's hybrid. It's very payer access driven. So we have private insurance that people get through their employers and that they pay for themselves. Or we have public programs like Medicare, Medicaid, and Veterans Affairs that are publicly funded and provide health insurance to people that way. So our insurance is either privately or publicly funded, but insurance is the key to getting healthcare in the US. Access to specialty care like genetic counseling can vary very differently depending on what insurance you have, where you're located, and your socioeconomic status. On the right, you can see there's a map of how genetic counselors are distributed throughout the US. There's definitely states that have a lot more and states that have very, very few genetic counselors for the population of the state. Cancer genetic counseling services are mainly through big academic medical centers, cancer hospitals, more increasingly to telehealth genetic counseling companies and testing labs offering testing. Next slide. I want to spend a moment talking about service delivery in the US because I think this is what's changing a lot over the next few years. We do have obviously the traditional pre-test and post-test counseling. I've seen a lot of practices do group genetic counseling where there can be pre-test counseling done for multiple individuals if they consent to the process at the same time. There's a lot of non-genetics providers offering testing, especially gynecologists and oncologists, but their understanding and training of genetics may vary very differently. I've seen some oncologists order just BRCA1 and BRCA2 testing for patients and telling them that's enough. And in a system like the US, testing for BRCA1 and BRCA2 and doing a multi-gene 91 gene panel will cost the same via insurance or self-pay. So it's really an injustice to the patient just ordering those two genes. But what I'm seeing increasingly is universal testing programs. And actually, the hospital that I worked at, it's called the Miami Cancer Institute, implemented a universal cancer genetic testing program where we started with a pilot to offer genetic testing to all cancer patients in the hospital. And this was enabled through a software, a genetics-based software that can collect personal and family history from the patient and have them consent to or do the pre-test consenting through the software. We know we have workforce issues, and to meet the requirement of everyone equitably getting care and getting cancer genetic counseling, we don't have the genetic provider workforce to do it. So the pre-test counseling can be done through this software, and was created by me and a few other people on my team. We created the pre-test story that the patients would go through. They would review material, and they could consent if they wanted through that software, or they could request a phone call or a video visit with the genetic counselor to complete the consenting. The software was great because we could order the testing through one button through the software. We were able to send out results through the software, create care plans that automatically integrated NCCN guidelines and a patient's personal history. We were able to send the software automatically used to send reminders for screening. Like if a patient had to go for their MRI or their mammogram, it would send them a reminder. It could create risk letters taking in their personal risk factors. It could create a link that if the patient consents, they could just send that link to the family member, and it would include a family sharing letter about their mutation, include their test report, and everything the family member would need to access genetic testing. And it would also reach out to the patient upon reclassification of their variant. Programs like this can really help increase uptake of genetic testing and volume of genetics clinics or cancer centers that don't have enough genetic counselors. Next slide. Okay. Genetic testing in the US is mainly commercial labs that are CLIA and CAP certified. These are mainly large, not like for-profit companies, and I have some listed here. These are the big companies that offer testing, but there's also academic centers, bigger centers like Memorial Sloan Kettering have their own in-house testing as well. And in principle, germline genetic testing for cancer is widely available. These labs make it very easy to order testing. I think what the issue comes in access to who will order this testing for the patient. Next slide. For along the same lines, for access in the US, we mainly follow NCCN guidelines for who should be referred to genetic testing. Sometimes but we can still see people who don't meet NCCN guidelines, maybe based off of patient interest, or some providers are referring all breast cancer patients to us as well, and not limiting it to guidelines just because they may need it for surgical decision making. But there's still disparities. We still are not seeing around 50% of people that meet NCCN guidelines are not making it to clinics or genetic counseling services to have genetic testing. And this could be for many reasons. We do know there's literature on how Black, Hispanic, and Indigenous populations are less likely to be referred to genetic counseling. This could be at the provider level because of biases that the provider may have, because of the provider's lack of familiarity, assumptions that the provider can make about the patient's interest or if they can afford testing and screening. But it can also be at the systemic level. There may be people that lack insurance coverage and cannot access these services, people that English is not their first language, people that are far away from genetic services or don't have access to telemedicine or internet as well. And the genetic counseling profession in the US is not very diverse, so people may not see people like them in the field either. Telehealth has improved a lot of these access issues in rural and underserved areas, but there's still many barriers to that, especially licensure. Licensure is basically there's 36 states of the 50 states in the US that have licensing laws for genetic counselors. So if someone wants to call themselves a genetic counselor in that state or practice genetic counseling for people in that state, they need to be licensed by that state's government. So that makes it hard because licensing is a long process for many states. It's an application with bigger fees. So it's not sustainable for a genetic counselor to be licensed in all of the states that have licensure. So even if I practice in Florida and I had only Florida licensure, so I couldn't provide genetic counseling services to a patient that was maybe in Virginia or New York where they have their own licensure laws. Okay, next slide. So the cost of genetic counseling, insurance is getting really good at covering cancer germline genetic testing, especially for people that meet NCCN criteria, but there's still insurances that will deny coverage. Medicare and Medicaid, which is our government-funded insurances, do not recognize genetic counselors as providers. So the reimbursement for the genetic counseling service itself is very poor for Medicare and Medicaid at the moment, but for genetic testing itself, the coverage is getting much better. And if there's no coverage, self-pay pricing and financial assistance through most of these labs is very, very accessible, with most labs offering panels, larger panels at $250, and that price can even come down with financial assistance. Next slide. For cascade testings, a lot of these commercial labs offer free of cost single site testing or panel testing for family members of people that test positive within a 3 to 6 month period of the positive report being issued. For these family members, we will send them letters. Like I said, we can send them those software links, or we give them this tool. The National Society of Genetic Counselors has a Find a Genetic Counselor tool that can help you find a genetic counselor around you. Some of the barriers are very similar to ones that in other countries, really, barriers to cascade testing remain same, it seems, along country lines. Next slide. Now we'll talk more about the high-risk screening and risk-reducing measures. Next slide. In the US, the service delivery for high-risk screening is mainly through high-risk clinics that are present in larger cancer centers, through the surgical or medical oncologists, or through gynecology clinics. Again, these clinics all will follow NCCN guidelines for screening, but there's many barriers and with compliance to high-risk screening. Some of it can include mistrust in the healthcare system in the US, because there have been a lot of historical examples of injustice and ongoing inequity in the healthcare system, and this can lead to lower engagement from the patient. Another barrier is the patient may be required to see multiple providers. For example, with BRCA1, they will have to see, they may go to a high-risk breast clinic, they will go to the gynecology oncology, a high-risk pancreatic cancer screening clinic. And for example, even in the hospital that I worked at, pancreatic cancer high-risk screening was not available in the hospital, so they had to do it at a different center. So they had to make appointments with 3 different clinics that may not even be in the same center and may require a different amount of resources. Some clinics may take their insurance, some clinics may not. So it's a huge ordeal to continue to follow up with multiple different providers. A multidisciplinary clinic can be helpful in removing some of those barriers. NCCN guidelines change with time as well. So the patient may not come back or return for follow-up, or the provider may not be aware of the new guidelines. And then there's some other issues like scheduling, travel time, access to providers that are other drop-off points for patients. Next slide. For risk-reducing surgery, those are widely available at least at most cancer centers. That there's lesser issues with access for it, but we have seen that white, high-income, and insured patients are more likely to take up, the uptake of the risk-reducing surgeries like mastectomy and salpingo-oophorectomy is higher in that population. Medicaid and some other insurance providers provide inconsistent coverage of these services, so there may be out-of-pocket costs for some patients, which is a huge barrier just because out-of-pocket payment for surgeries is very high in the US. Next slide. Precision oncology as well. The PARP inhibitors and immune checkpoint inhibitors are FDA approved and also widely available at most major US cancer centers. And even somatic testing is routinely offered to find other additional therapeutic targets. But I think the main barrier here is that we're not testing everyone that may benefit from getting these therapies. But universal programs and offering testing across the board to people can help with these barriers. Next slide. Now let's talk a little bit about the ethical, legal, and social implications. Next slide. There's many populations that can be described as disadvantaged or vulnerable in this healthcare system. I'm not going to go through all of these, but just like the UK and Australia, we have a melting pot of people. We have people from all over the world that immigrate to the US. So we have racial and ethnic minorities, people of lower socioeconomic status, people that are in more rural areas, people that are non-English speaking, with people that have limited health literacy. The LGBTQ plus population has its own challenges with experiencing discrimination and bias in the healthcare system. People who are uninsured, and people that may already have a burden from serious illness or caregiving responsibilities. They all come with their own unique barriers in navigating this very extremely complicated healthcare system. Next slide. We have a lot of legal framework to safeguard people in the US from genetic discrimination. The biggest one is the Genetic Information Non-Discrimination Act, or GINA, that stops health insurance and employers from using genetic information against someone. But this law does not apply to life insurance, disability insurance, and long-term care insurance. On the state level, for example, Florida actually is the only state that has legislature that stops life insurance, disability, and long-term care from discriminating against people. So depending on which state the patient is or which state they get those insurances in, there may be other laws that apply. The US also has a HIPAA law, which basically is a law that protects the patient's privacy. If you divulge any information about someone's like a personal health identifier of the patient, including name, date of birth, that is against the law. And it prohibits use of disclosure of any sort of genetic or personal information of the patient. The FDA regulates genetic testing in the US. The Affordable Care Act is kind of like an extra layer of protection on top of GINA. It guarantees insurance coverage for individuals who have pre-existing conditions, including some genetic conditions. And then there's the American Disability Act, which prohibits discrimination in employment and other areas based on disabilities for people. On top of these laws, a lot of genetic testing labs have their own privacy and data sharing policies that also protect the patient. Next slide. There's a number of genetic counseling approaches that can be used to safeguard these individuals. I've just listed some of them here: getting informed consent, meeting the patient where they are with their risk perception, referring them to support services. We have licensed and trained social workers and mental health services in most major medical centers here in the US. Those can be great resources, including support groups and providing culturally competent care to patients and ensure an equitable access of all care to patients. Next slide. So I'll conclude there with just this on there. The US, like I said, is, unlike the other countries that we have spoken about, is a very payer-driven access place. We don't have a single payer system like the UK and Australia. A lot of things are determined by private insurance coverage, and this creates a lot of financial disparities in who gets access to services over here. And I think a lot of cancer genetic counseling in the US is moving towards universal testing only because there's so many barriers for people to get access to genetic testing or genetic counseling services right now. But there's a lot of benefit to them having the genetic counseling and testing because it can change the way that their care is managed in the future through this system. And with that, I will stop. Hopefully that was under 20 minutes.
So thank you very much, Shrika. You gave an excellent talk. And few things were really, I mean, it was, so what you said that US has probably the largest number of genetic counselor and cancer genetic counselors, 6,000, of which 1/3, 2,000 are in US. So I think rest of the world together, US probably has more genetic counselor and cancer genetic counselor. Despite that, you said so many people do not get testing or they have to, wait or so many things. So the approach of universal testing just to overcome those, so that I find little quite innovative. And because the next challenge would be to do counseling. So the software that you were talking, and I'm glad you were involved in developing that. Has it been tested really, that software, to how it works?
So the great thing about the software that we use is we worked with a platform to make it and personalize it for our own
Have you
institution,
given
right?
it a name? Have you given it a name?
So it's a company. The company's name was Nest Genomics. So they created their own model, and then they integrate that model into the healthcare system that they're working with. So they worked with us personally to create something that was specifically made for our patient population. We made it in English and in Spanish because in Miami, most of our population speaks Spanish primarily. So what was great about it is that we made it ourselves, we piloted it ourselves, and the uptake was really high. We were seeing 200 more people a month through that program than we were through the traditional model. And we were testing everyone with ovarian cancer, everyone with pancreatic cancer. But up until that point, we were seeing only about 30% of ovarian cancer patients being referred to the traditional model. So I can't speak enough about how helpful that model was in increasing uptake and providing care across the board, making sure that the provider is not a barrier in the patient getting genetic counseling and testing.
So I think that's a wonderful, concept. And I think all parts of the world, we need to emulate that, and we have to develop it our own. Like you said, it has to be culturally adapted, all the cues. So thank you very much, Srika. Anyone else who is online? Let me see. Aparna, Abir, Ariba, Dipanjana, all of them are you online. If anyone would want to say anything, few words or whatever, then we will close the. And let me just tell you, because the consensus we were going to have it, all the recordings are there and our rapporteurs are there. So they will look at it and then we will make and then share. And the aim is that finally, each of these three themes we will try to collate and bring out as a publication, scientific publication, and maybe we'll have some more collaborators to bring out what is common, what is unique in different parts of the world. And in the end, finally, make some suggestion how to overcome those, barriers. Otherwise, just bringing out the barriers, of course, that's very important, but also give some suggestion. I think a lot of unique points have come. So Abir, you want to say anything? Some
I think I would, again, thank the organizing committee and special thanks to you, Dr. Sarin. I don't know how you do it, but you do it. You collected us all in one day to discuss our experience.
No one ever says no to me.
Exactly. So thank you for that. I think I would like to leave with, I think, collaboration. I think, the best way to go forward, and we can explore this in detail in the coming days, is collaboration would really, be fruitful, because it seems that, despite the geographical distance and the, all of the, some people may call it disparities, we are the same. So I think we need to work together on, proving our point to the world that this is not a luxury. This is a test that is as important as the other routine tests by doing research. Thank you.
Thank you. Ariba?
It was very refreshing to be here today and to enlighten myself of so many different perspectives and to relive some experiences from India. I think I'd just like to give a takeaway message that we are more than anything, we are advocates for our patients, and sometimes we go beyond our roles and responsibilities, and that one patient that we go above and beyond for may mean a lot. It may mean a lot for that individual and family. Every patient is different, but we just have to keep striving to be the best versions of ourselves and work to improving, and thank you for Dr. Sareen for giving us these kind of opportunities to learn and grow and just take in everything that is out there to be a better version of ourselves.
Thank you. Aparna, Dipanjana, you are there. You want to say something? No? Okay. So, Brinda, you want to say some concluding comment? Come and say.
No, I agreed to what everyone shared. Collaboration is the way to go. I also thought that between the themes, there were themes like India stood out on its own. Then we thought Malaysia and Middle East were similar themes. US stood out on its own with its challenges. And I thought UK and Australia were kind of similar in their challenges. So there is more to share and a lot to learn from each other. And I'm surely going to go over the recording one more time. Thank you again for having me here and the wonderful students. It was a fantastic day.
Okay. So thank you. And thank you all. And now, Shrika, you can enjoy your holiday, public holiday, Veterans Day. Bye-bye. Thank you very much. Now we'll have a photo session with the graduating batch. Thank you. Thank you. Bye-bye.
Thank you.
We're ending the session.
Bye-bye. Thank you.